All right, so as Dr. Fancher mentioned, my name is Danielle Roman. I'm at Allegheny Health Network in Pittsburgh, Pennsylvania. Thank you for sticking with us today. This is not a misprint. We have a lot of time together. And I think a lot of you probably know why that is. Breast cancer is a huge topic to cover. And it can be overwhelming, and it's overwhelming for me. So if you feel that way, you are not alone. Very difficult to keep up with the breast cancer literature. So we're going to try to break it down today. My hope for all of you is that you're feeling just a bit more comfortable by the time we get to the end of this and kind of able to make sense of some of it at least. Okay, disclosures are listed here. Learning objectives, like you've seen in other sessions, really the focus is going to be on the treatment options for patients. So we're going to try to break down how we make those decisions and what makes most sense in line of treatment. We're going to also sprinkle in some supportive care topics as they're relevant to breast cancer management. There is, as others have mentioned, much more in the handout. So in terms of those of you studying for an exam, there is relevant information on screening and prevention related to breast cancer that's going to be important for studying, and that you can find all of that detailed in the handout, and we're not going to focus on it today just purely because of our time constraints. And we're going to break this down. So you probably also saw that we have a built-in break, and I think we're all going to need that probably in our time together. So we're going to start with a part one, and then we'll take a break and move into part two. So part one of our focus will be on early stage breast cancer and how we make decisions in the early stage setting. So some of the decision-making tools that are available to us, and also that focus on systemic therapies for our patients, so such things as endocrine therapy, chemo, and some of the targeted therapies that have become really important in management of early stage. And then we're going to talk about one of our key supportive care topics in this patient population with cardiotoxicity. So in breast cancer, this is often a multimodality treatment strategy. So we need to be thinking about multiple different things in the treatment of pretty much every patient out there. So we need to think about things like our local therapy approach with surgery or radiation. And then we also have to be thinking about systemic therapies for nearly all of our patients. So those are some of the things we just mentioned with chemotherapy, endocrine therapies, targeted therapies, or combinations of those. So how we make selections based on that is going to be something that we talk about in the coming slides. But I find one of the more challenging things in breast cancer can just be understanding sequencing of agents, and so that's why this slide is put together for you. So as we kind of talk through each of these separate categories, how we sequence them is listed here. So for our patients that can start with surgery, after that, if they need adjuvant chemotherapy, that would kind of be the next step in things. Radiation would come after chemotherapy if it's indicated. So usually we sequence them that way, kind of sandwich chemotherapy between the surgery and the radiation. If patients need endocrine therapy, it's going to be after chemotherapy. So in terms of principles of breast cancer management, that's a really good one to know, and especially in the early stage disease. Patients that need chemo and endocrine therapy, we don't give them concurrently. So it's going to be your chemotherapy, then your endocrine therapy following that. And then there are some situations where we might use some targeted agents, and you see those listed here and how we sequence that. And we'll talk about HER2 targeting agents and how they fit in, but basically just to know that they go along with the chemotherapy course. Just a brief mention of our local therapies. This is a really important consideration for all of our early stage patients. Surgical options here include a lumpectomy or breast conserving surgery. So this has become a mainstay of treatment and is really just based on the patient's desires for surgeries and also whether there can be a good cosmetic outcome. So several considerations here. And then our other option being a mastectomy or complete removal of breast tissue in the affected breast. Radiation therapy may be required. So it is often something we say is plus or minus, and it's dependent on a lot of factors that we're not going to delve into today, but just to know that it is included for some patients, may not be needed for all patients. But an important consideration is for most of those patients that get that lumpectomy or breast conserving surgery where they're only taking out a portion of the affected breast, those patients often do require radiation. So it is not 100% for nearly all of those patients will require radiation following their surgery course. For those patients that get a mastectomy, it's again based on a lot of specific factors, the original size of the tumor, the number of affected lymph nodes, are some of the things that might be considered in that decision making. Another area in early stage that has really got a lot of attention and has made its way into guidelines, so really important in the management, is kind of de-escalation. So is there ability to de-escalate therapy for patients where they don't need as much as we previously thought? So there's been a lot of efforts at looking at the ability to do that. And some of those efforts have been in the form of gene expression assays or genomic assays. These, again, are built into guidelines, so we're going to talk about exactly where they fit. But they provide important prognostic information for patients, so tell us something about that patient's disease course and whether they are projected to have a good outcome with therapies. And also give us some information about whether chemotherapy is needed or not, so have some predictive value here as well. I'd like to call out Oncotype DX. It's one specific test that the guidelines really have said has both prognostic and predictive. So that predictive is really important. There's going to be other tests that we talk about, but specifically NCCN does call out that test as having some really good data backing its predictive abilities. Important here too for all of you is the second bullet point is where these are recommended. So most patients with early stage disease will fall into this category, but not all. So the patients that we are going to use these tests are patients with early stage disease, so not in the metastatic setting, patients with hormone receptor positive, HER2 negative, and either lymph node negative or have a small volume of lymph nodes, so 1 to 3 positive lymph nodes. So these are patients that are really generally considered to not have very high risk disease. So they either have kind of a low or moderate risk disease that really that consideration for chemotherapy is being made. Do they really need it or not? And so these tests help us to determine that. They're not recommended in those highest risk patients, so patients with something called triple negative breast cancer. So that means they're negative for 3 things. They're negative for estrogen and progesterone, so our 2 hormone receptors, and also negative for HER2. Okay, so a higher risk patient population. Also those patients with HER2 positive disease, generally considered to have a poorer prognosis compared to HER2 negative. And those patients with a lot of lymph nodes. So here that's a cutoff of 4 or more lymph nodes. Any patients in these categories, we are currently not using these tests routinely. So there, I mentioned Oncotype DX. There are some other tests available. MammaPrint, Prosigna, EndoPredict, and Breast Cancer Index are some that are mentioned in guidelines. Certainly could be seen in practice, but I think what I tend to see more of in my practice is Oncotype DX and sometimes the MammaPrint test. So a little bit more about the Oncotype DX. We're going to spend a little bit more time here because NCCN does give it a higher level of evidence. So it is, again, predicting the likelihood of recurrence of breast cancer, so that's the prognostic ability, and then assessing the benefit in patients. And we called out that specific subgroup of patients that we're looking at, so the predictive value here. And what this is really just a piece of the tumor, so that can be a biopsy or a surgical specimen, that is measuring the expression of 21 genes, so 16 that are cancer-related and 5 reference genes. And patients are assigned a recurrence score, or RS, as you'll see designated, and that's on a scale of anywhere from 0 to 100. Typically, it's grouped into a low, intermediate, or high risk based on that recurrence score. So higher the score, the higher the risk of recurrence, and increased benefit with the addition of chemotherapy. One large trial that really was landmark in changing guidelines in the management for a lot of these patients was the TAILOR-X trial. So this, as you can see, very large trial for oncology. So over 10,000 patients included here. And this is looking at the Oncotype DX predictive ability. So again, the patient population we talked about, so hormone receptor positive, HER2 negative, lymph node negative patients. And they took that recurrence score and they assigned patients into 3 groups. So either low at 0 to 10 recurrence score, those patients got endocrine therapy alone. That intermediate group, 11 to 25, were randomized. So this was the only randomized part of the trial. Here they randomized patients to either endocrine therapy alone or endocrine therapy and chemotherapy. And remember, when we do that combination, we have to sequence them appropriately. So the chemo comes first, the endocrine therapy comes after. And then that high-risk group, so anything greater than a recurrence score of greater than 25, those patients are considered to be high risk, and they're going to need both chemotherapy and endocrine therapy. So this trial kind of had 2 main goals. They were looking at that low-risk population just to confirm that endocrine therapy alone is sufficient, and they did find that that was the case. So very long follow-up at 12 years here, and you can see that very good outcomes for these patients. So that was considered, positive, and that endocrine therapy alone for these very low recurrence scores is sufficient. They do not need chemotherapy. What the focus was here was this intermediate subgroup. So again, this is where the randomization was happening to look at whether chemotherapy is needed or can we get away with endocrine therapy alone. And at this 12 years of follow-up, they found that endocrine therapy was non-inferior to the combination. So really showing that endocrine therapy alone is sufficient for patients, most patients in that low and intermediate group. So anything recurrence scores of 25 or less, most of those patients do just fine without the addition of chemotherapy. But, as there is in a lot of oncology, there's always a but out there. There is a select group of patients that they did find that in that intermediate category that did have some benefit from the addition of chemotherapy. So these were younger women, so less than or equal to 50 years of age, that had a recurrence score that was in that intermediate range, but it was kind of in the higher end of that range, so that's 16 to 25. So those patients did appear to have a benefit with the addition of chemotherapy. So guidelines, I just want to call that out because you'll see that in the guidelines. RxPonder trial, just to briefly cover, this is very similar to what we just talked about. This is also looking at Oncotype DX testing. The difference here is that with the TAILORx trial, those were only lymph node negative patients. The RxPonder trial is including patients with 1 to 3 positive lymph nodes, so low volume lymph nodes, also in that low to intermediate category. And they randomized them very similar here to endocrine therapy and chemotherapy or endocrine therapy alone. You can see most of these patients were postmenopausal, as we would expect, this patient population. At 5 years of follow-up here, it found that there was no benefit with the addition of chemotherapy in the postmenopausal women. So the majority of patients making up that category found that it was fine to just do endocrine therapy alone. Chemotherapy is not needed unless they're truly in that high risk of 26, recurrence score of 26 or higher. Okay, so really anything less than that, they did pretty well with just endocrine therapy alone. Where, again, there's always a but, so in the premenopausal patients, there does appear to be a benefit here of chemotherapy. So lymph node positive and premenopausal, even though a small number of lymph nodes, the premenopausal patient population is just a higher risk patient population, so it does appear that chemotherapy can benefit some of these patients. And then one brief mention of the MindJack trial. So I said one of those other those genomic assays we can use is the MammaPrint test. So this was the study supporting MammaPrint. Again, another large trial, very similar patient population here. MammaPrint is a little bit different. So in terms of this trial, they did two risk assessments. They did a genomic risk assessment with MammaPrint test. They also did a clinical risk assessment with something called Adjuvant Online, which isn't available in its form that it was used at the time of this trial. But this study really focused on those patients that had a high clinical risk. So was that providers assessing the patient, they seemed to be at high risk for recurrence of disease, but the MammaPrint came back that they had a low genomic risk. So sort of a quandary of, do they need chemo or do they not, because they had that low genomic risk. So they found here that in all patients there was not a benefit with the addition of chemotherapy. But again, there's a carve out here in those younger patients. The theme being those younger patients, for the most part, do need the addition of chemotherapy. So especially those patients with lymph node positive disease, or those patients with kind of the intermediate to high end there was a benefit with chemotherapy. So in particular in this study as well, they found that those high clinical risk, even though they had a low genomic risk, there was a benefit for chemo. So ASCO has a number of guidelines in breast cancer. You've probably seen, I think we're more than 20 now maybe in breast cancer specifically. But they have a guideline that's looking at these biomarker testing in early stage breast cancer. So this is just a summary of what's in that guideline. And you see they differentiate postmenopausal and premenopausal. And that's because of the results that we just presented from those 3 trials, really seeing a difference, or some difference in those patient populations. So they say for postmenopausal patients, or patients that are over the age of 50, that meet the qualifications for the testing, so the things that we've talked about previously, there are options here. So Oncotype DX, MammaPrint, EndoPredict, Breast Cancer Index can all be used for these patients. For those patients that are premenopausal or a younger age of less than or equal to 50 years, again, meeting our hormone receptor positive, HER2 negative, and lymph node negative. So in these lymph node negative premenopausal patients, Oncotype DX is the preferred testing to be used. These tests, none of these tests that we've talked about are recommended in higher risk patient populations. So 4 or more positive lymph nodes. Those premenopausal patients that, even though they have small volume lymph nodes, they do appear to have a benefit for chemotherapy. Triple negative breast cancer patients, and HER2 positive. So in practice, we are not routinely using these tests for these patient populations because we know that they benefit from chemotherapy. So we really don't need this decision maker tool. Okay. So on to our first ARS question. JH, a 39-year-old premenopausal woman with estrogen receptor positive, progesterone receptor positive, HER2 negative, lymph node negative, early stage breast cancer. She has a recurrence score of 26. What is the most appropriate adjuvant therapy for JH? Would you choose anastrozole, chemotherapy with docetaxel and cyclophosphamide, or TC, followed by anastrozole, tamoxifen, or the option of chemotherapy again with TC followed by tamoxifen? So we want to think about recurrence score. We also want to think about this patient's menopausal status here. Okay, excellent. So this is a patient, she's got a high risk recurrence score. Okay, so she is over 25. She's at just over that, but at 26, that's putting her in a high risk category. So we know that she needs chemotherapy. She also has also needs endocrine therapy because she has hormone receptor positive disease. So you're going to see that theme throughout. And this patient is premenopausal. So we'll talk through our endocrine options, but anastrozole would not be appropriate for this patient because anastrozole is indicated in patients that are postmenopausal. Okay, so she would need tamoxifen. And so the combination of tamoxifen based on her higher our recurrent score and the fact she's premenopausal leads us to our last option here. Okay. So I implore you to stick with me for the next several slides. I understand that this is overwhelming. Guidelines are overwhelming, but I'm going to try to walk through it. We're going to try to make sense of this together and how to kind of break down the treatment for these patients. So we're going to look at these based on several factors. So you really need to know 5 things here, and these 5 things are kind of what's listed at the top of the slide. So to make treatment decisions in early stage breast cancer, you need to know something about the size of the tumor. You need to know something about whether the patient has positive lymph nodes or not. You need to know the hormone receptor status of the patient. If a patient is either estrogen receptor positive or progesterone receptor positive, either one of those or both of them, that patient has hormone receptor positive disease. Okay, so we need to know that whether they're hormone receptor positive or negative. We need to know the HER2 status, so negative or positive. And then our fifth thing here, particularly for patients that have hormone receptor positive disease, is the menopausal status, so pre or postmenopausal. So those 5 factors you need all of those really to make some treatment decisions here. So we're first going to walk through patients that have either lymph node negative or small volume lymph node positive disease, hormone receptor positive, HER2 negative, and postmenopausal. So this happens to be where the majority of our patients are going to fit into this first category. And you can see that NCCN guidelines breaks it down by looking at these factors. You can see for most patients that we're going to require some form of systemic therapy. Okay? There are some patients with very small tumors, this top line here, very small tumors and no lymph nodes, that you can see endocrine therapy is a consideration, but vast majority of our patients here are going to require some systemic therapy, typically with endocrine therapy, and then we're going to kind of look at where chemo fits. So for patients that have a tumor that's greater than 0.5 centimeters, so this middle box, that either have small volume micrometastatic lymph nodes or have some degree of lymph node positivity, this is where patients are going to fit in for that Oncotype DX testing. So that's what that middle box is when it says the 21 gene RT-PCR assay. That is Oncotype DX assay. And so you can see options based from here, and hopefully some of this makes sense based on what we just talked about. If it's not done, patients should definitely get endocrine therapy because they're hormone receptor positive, okay, plus or minus chemo. We don't have that recurrence score guiding decision making, so we're really going to be looking, patient provider decision making here. If the recurrence score is less than 26, so this was that low or intermediate risk category with a postmenopausal patient, we don't need to add chemotherapy. Okay? So remembering that postmenopausal patient is important to know here, but endocrine therapy alone is sufficient. For those patients that fall into that higher risk category, so that recurrence score of 26 or higher, these are the patients that are going to benefit from the addition of chemotherapy. And remember the sequencing here is chemotherapy followed by your endocrine therapy. And then patients with the high volume lymph nodes, so 4 or more positive lymph nodes, this is where chemotherapy is going to be added in. So notice no need for the Oncotype DX testing, that we would give chemotherapy followed by endocrine therapy. So we're going to switch things a little bit here and notice that we're talking about premenopausal. So the last slide was postmenopausal, so this is premenopausal, still sticking in that with that hormone receptor positive, HER2 negative. And these are patients that do not have lymph nodes, so lymph node negative. Again, you see small volume tumors, or very small tumors, no lymph node involvement. You can consider endocrine therapy, so plus or minus here. For those patients that have more than a 0.5 centimeter tumor, this is again where our Oncotype DX testing fits in, but notice that your recurrence score cutoffs are different from what we just looked at on the last slide. And that's because of some of those nuance that we saw in the premenopausal patient population. So you can see if it's not done, endocrine therapy, plus or minus, that OAS is ovarian ablation or suppression. So we will be talking through that in some of the coming slides. Plus chemotherapy. If patients have a low recurrence score, and you can see, notice here it's pretty low, so less than or equal to 15, you don't need to add your chemo. So endocrine therapy alone, plus or minus ovarian ablation suppression. For those patients that have that intermediate recurrence score of 16 to 25, but remember, premenopausal, the higher end of that, they did seem to have some benefit from chemotherapy. So this is where chemotherapy would be indicated as an option, but it's still not a requirement. So endocrine therapy alone, or you could do the chemotherapy endocrine therapy option. And then again, high risk, as we've been talking about, in that 25 or greater, chemotherapy has benefit. So we would be doing both of those modalities. Okay. So again, switching things a bit here. This is that same patient population we just talked about. The only difference on this slide is this is lymph node positive patients. So that is the only difference. For those patients that have low lymph node positivity, if they're not a candidate for chemo, you're not going to give chemo. Okay, so endocrine therapy alone, with a preference to add in ovarian ablation or suppression, would be preferred. If they're a candidate for chemo, you can consider doing something like the Oncotype DX testing here, and then making your decision based on that score. So either chemotherapy followed by endocrine therapy, or potentially endocrine therapy alone. So this is kind of that little bit of a gray zone. And then, as we've been saying in all of these slides, for patients that have a higher volume lymph node positive disease, you need that chemotherapy addition. Okay. So the difference on this slide is we're now switching to patients that have HER2 positive disease. Okay, so that's the big difference here, HER2 positive, and we're looking at patients that have no lymph nodes. And you see no differentiation here for the pre or postmenopausal, so they're both included on this slide. Notice no Oncotype DX testing, and that's because these patients are HER2 positive. We said it's not used in that setting, just a HER2 negative patient. So again, just quickly walking through these top slides here, if it is a very small tumor, even if it has a very small tumor with no lymph nodes, this is where you can consider systemic therapies. Maybe just surgery alone could be considered for some of these patients with these very small tumors. If you're choosing to be more aggressive here, endocrine therapy could be considered because they're hormone receptor positive, so that should make sense that endocrine therapy is going to be included for all of these patients. Plus or minus chemo with these small tumors, so very provider patient specific decision. If chemo will be given because these patients are HER2 positive, you are going to see some HER2 targeted therapies added in. Okay, so that's where we start to see some of these therapies added. For patients that have a little bit larger tumor or maybe some micrometastatic mets in this middle section of the figure, this is where endocrine therapy is definitely going to be given, plus or minus chemo. And again, if chemo is considered, we're also going to add in trastuzumab or HER2 targeted therapy. So I hate to give you some gray, but there is some gray here in guidelines. For patients that have larger tumors, so this is considered more than 1 centimeter, this is really where we have the data that supports chemotherapy and HER2 targeted therapies with trastuzumab in this setting. So this is where it is a definite recommendation. Because these patients are hormone receptor positive, they're going to get endocrine therapy, but because they're HER2 positive, they're also going to get trastuzumab and chemotherapy, just because this is a higher risk disease with that HER2 positivity. So they're going to get all of those strategies. So notice no plus or minus. This is when you are going to give all of these. There is a mention on these slides about using the adjuvant bisphosphonate, so I just want to note that is on here, and we will talk about that in a future slide. Okay. I know a little bit crowded here too, but you'll notice one of the big differences here is we've now moved on to hormone receptor negative. Okay. One of the things to point out is you don't see any mention of endocrine therapy. Okay, so it should make sense to us. The patient does not have positivity in those either estrogen or progesterone receptors, so we're not going to be using those endocrine therapies. You're really going to see chemotherapy as the backbone. You're also going to see HER2 targeted therapies if that patient is HER2 positive. So some core principles that you can kind of apply as you think through these patients. Small tumors, it's going to depend somewhat on the lymph node status here, and then you see the breakdown on HER2 negative or HER2 positive. And really, there's consideration for what to do, as there's not a right or wrong in these very small tumors, again, but if you're going to give chemotherapy, and the patient is HER2 positive, you're going to add in that trastuzumab option. Mid-sized tumors at 0.6 to 1 centimeter, again, consideration for what you're going to do with systemic therapy, so it is not an absolute. Where we get to more absolute is those patients with the larger, greater than 1 centimeter tumors, where adjuvant chemotherapy is definitely recommended. And then, as makes sense, if the patient is HER2 positive, that's when you're going to add in your trastuzumab option here. So, a tough thing to memorize, but I would recommend just some of the cores here of knowing that patient is hormone receptor positive. Endocrine therapy is generally recommended. Hormone receptor negative, it's not. HER2 positive, you're generally going to add in something like trastuzumab. HER2 negative, you're not. So just kind of remembering some of those as you think through these patients is really important. Okay. And then kind of wrapping up here with our algorithms, this is purely looking at patients with lymph node positive disease. So some of this was included on the things we just talked about, and you'll see where it says see previous algorithm that we've already talked about some of these patients. But again, it should, hopefully as you look through these and kind of make sense of it, hopefully it makes some sense in that those patients that are hormone receptor negative, notice you don't see endocrine therapy option. For those patients that are HER2 negative, you're going to see really chemotherapy, no trastuzumab added. I'd like to highlight here the very bottom where you see those patients that are hormone receptor positive and also HER2 positive. You see adjuvant chemo plus trastuzumab, and you see plus or minus pertuzumab here. You also see it above where it's hormone receptor negative HER2 positive. So the lymph node positive patient population is where you're going to see pertuzumab added to trastuzumab. Okay, so that's a new drug for us to talk about, and this is really where that fits in, is that lymph node positive patient population. All right, so this is not a new one, so we're just bringing us back to our patient case. So you got through all the tough stuff, I promise you. So we're just going back to our patient case. So remember JH, she fit into that recurrence score of 26 category. So she's in that high risk category. We chose, she needed chemotherapy and endocrine therapy. So this is how you kind of apply some of these algorithms to specific patients. So we're going to use this roadmap as we go through, and we're going to walk through some of these categories. So we got through the tough stuff of looking at, all those factors to determine a treatment strategy. Now we're going to really dive into each of these specific treatment strategies to better understand what it means to say endocrine therapy, what that is. When we say chemotherapy, what that is. So we're going to dive into, and we'll kind of use this again as our roadmap. Most of our patients are going to be hormone receptor positive, so probably about 70% of our patients or so fall into this category. So that's a vast majority that are going to need some form of endocrine therapy. And we're going to talk through our options here with tamoxifen, our aromatase inhibitors or AIs, and then also I mentioned before OAS or ovarian ablation or suppression. And this can either be done in combination with tamoxifen or an AI. You're not going to do this by itself. You're going to be adding that ovarian suppression to one of either the tamoxifen or the AI class. And then some information here and starting to use targeted therapies that we'll talk about. So on to our next audience response question. This is CW. She's a postmenopausal female with a T2N2M0. She has 4 positive lymph nodes here. She is hormone receptor positive, HER2 negative. She received neoadjuvant chemotherapy followed by breast-conserving surgery and radiation. What is the most appropriate adjuvant endocrine therapy for this patient? Is it anastrozole plus leuprolide, anastrozole plus abemaciclib, anastrozole by itself, or tamoxifen by itself? Okay, so option here, so you guys got it right in that we're thinking about menopausal status for these patients. So tamoxifen could be an option. We'll go through that a little bit. So it could be an option, probably not the best option for our patient. This first one here with using an AI plus leuprolide, so the AI portion I can get on board with. The leuprolide, that is considered ovarian suppression, and that is something for just a premenopausal patient. So we will go through that in a bit more detail, but because CW is postmenopausal, that first option is not an appropriate option for her. AI, definitely agree with. So, those of you that chose a second and third option, I agree with that. I think where the nuanced here is we're talking about a high-risk patient. So this is a patient that had 4 positive lymph nodes. And so we do have an option now with abemaciclib to be more aggressive with these higher risk patients. So again, we'll go through this data, but this patient, it would be most appropriate to give the combination. So our options, if we purely look at our endocrine therapy options here, and you have to know the menopausal status of a patient. You cannot make any treatment decisions without that piece of information. Across the board, tamoxifen can be an option in both menopausal status. So it's really the only one that sort of crosses both of these menopausal status, and that's because it's acting at the level of the breast cancer cell. Okay, so it's not working on kind of any estrogen production, but it's working at the level of the breast cancer cells, so you can use that in both menopausal statuses. In the premenopausal status, tamoxifen really is our mainstay option. You do also see that we could use OAS, so ovarian ablation or suppression. So you can either do ablation by surgically removing the ovaries or radiation to ablate the ovaries. You can also do this, and probably more commonly what we see done is using suppression. So using that class of the LHRH agonists, or also GnRH agonists, so things like leuprolide, gaserelin, triptorelin. So those drugs that are shutting down ovarian production of estrogen. It really only makes sense to use these in the premenopausal patients. So if you think about postmenopausal patients, they're not having any more production of estrogen from the ovaries. So you don't need to shut down the ovaries. So it's really just that premenopausal patients where those drugs are appropriate. And as I mentioned before, if you're going to use them, you need to do them in combination with another agent. So like the tamoxifen option, we can also use an aromatase inhibitor here. So generally we think aromatase inhibitor postmenopausal. So if you thought that, that is exactly correct. The only time you can use an AI in a premenopausal patient is if you combine with ovarian ablation or suppression. So you have to have something else for that premenopausal patient to work on the ovarian production of estrogen. So postmenopausal, switching over to that. So we said tamoxifen can be an option here. It's generally not our preferred option. So what is preferred, if you want to star something here, is going to be your aromatase inhibitor class. So that AI class is the preferred. So there's better disease-free survival. When they looked at AI compared to tamoxifen, it does seem to have some benefit there. So that is the one that most people will go to. There's been a number of studies done that we're not going to go into the details, but a lot of sequencing studies that looked at AIs and tamoxifen combinations, so it could be appropriate to do that. But in that postmenopausal patient, if they can receive an AI, that is going to be the preference. If they cannot, which is generally in the case of they are intolerable to some of the AI side effects, that would be a patient that tamoxifen could be appropriate. So specifically looking at menopausal status, we're going to focus first on the premenopausal and kind of how this actually fits in, how we use those options we just talked through. You're going to generally see across the board the options for endocrine therapy given for between 5 and 10 years total therapy. So that's a good principle to know when you think about endocrine therapies, regardless of pre or postmenopausal, generally that 5 to 10 years. So it's a long course of therapy for patients. If we look at the premenopausal patients, so we have 2 options here, or really 3 options. So you can do tamoxifen alone, or we say the plus or minus, adding the OAS. We also said there's the option to use an AI, but you have to add, so no plus or minus here, you have to have that OAS combination. So generally looking at this, we would do those combinations for 5 years. Okay, so that's the data with the combination really is just 5 years. So after 5 years in a premenopausal patient, it's recommended to assess their menopausal status. So either tamoxifen alone or the combination strategies here, assessing whether they remain premenopausal or whether they become postmenopausal in that time period. If they remain premenopausal, you could stop therapy at that point. So it's an option just to stop at 5 years, or you could consider continuing tamoxifen by itself for up to 10 years. For patients that have become postmenopausal in this time frame, it's recommended to give an AI. So we know that AI has benefit in the postmenopausal patient population. So it's recommended to go that approach, so doing an AI to complete 5 additional years of therapy, so a total of 10 years of endocrine therapy. Or you could consider just continuing that tamoxifen for up to 10 years. And then for those patients that had the bottom part of the algorithm here where you started with the combination with the AI, if they are postmenopausal, you can consider just that AI alone for an additional 3 to 5 years, so a total of 8 to 10 years. Or you could stop at 5 years. So there's, again, the gray area, but there's some option here, but knowing somewhere between 5 to 10 years is going to be that duration, that prime duration. Postmenopausal here. So there's a lot to look at, but I'm going to point out what I think is most important. Okay. So most patients are going to follow the top line here in this algorithm. So starting with an AI for at least 5 years, and then you could consider stopping at that point or going beyond that to a total of 7.5 or roughly 8 years to a total of 10 years. You might want to do a higher, more of the 10 years in a higher risk patient. So the example of ASCO guidelines really calling out if patients are lymph node positive, that's probably where you want to push it to 10 years. But really a lot of provider and patient decision making that's happening, whether patients really want to push on to 10 years for some potential added benefit that we'll talk through, or whether maybe they've struggled with getting through the last 5 years and want to stop at that 5-year point. So there is some wiggle room there for decision making. Notice then there's a lot of these sequential. So there's tamoxifen for this long, followed by an AI or vice versa. So just knowing that you have these sequential options available, but going anywhere out from a total of 5 to 10 years of therapy. And then as we mentioned before, if a patient can't tolerate an AI, then tamoxifen alone could be considered in the postmenopausal patients. So a little bit about more than 5 years. So 5 years was the standard for a long time. And then here's a little bit of the data that may kind of encourage some patients to push beyond that to 10 years. So there's 2 main trials with this and tamoxifen, so the ATLAS and the ATOM trial. So examining 5 years versus 10 years of tamoxifen, so decreased risk of recurrence in both of these trials, decreased mortality in one of these trials, so that was not consistent in both of them, but a decreased risk of recurrence, but at the risk of more toxicity. Okay, so higher rates of venous thromboembolism with PE in the ATLAS trial, and then higher rates of endometrial cancer, which we know is a rare but serious toxicity with tamoxifen, and endometrial cancer-related deaths in the ATOM trial. So there, again, it's a more rare toxicity to see, but the risk is there with the longer durations having a higher risk. So the trade-off is that. So that's why the guidelines really state to consider that additional 5 years of tamoxifen after the initial 5 years. And again, decision based on potentially reducing the risk of recurrence, but at the risk of more toxicity. So AIs, we mentioned we could also go beyond 5 years with the AI, and this is really based, again, on a couple of trials. The MA17R showed that there was no difference in overall survival, but a difference in disease-free survival with that 10 years of AI versus 5. So sort of inconclusive, not firm 10 years is better, but the potential that 10 years might provide some benefit to patients. And then they thought, well, if we know that 10 years is better than 5 from the disease-free survival standpoint, what if we kind of split it down the middle and said 7? So is 7 or 10 years better? So that was the SALSA trial. And they found that really disease-free survival was identical with 7 versus 10 years. So we might not need to go out to 10. Maybe 7, kind of pushing it to 7 years might be enough. So again, breast cancer is just, there's a lot going on here, but I think if you keep that 5 to 10 year duration in mind is really important, and then maybe pushing it for patients that are higher risk, closer to that 7 to 10 years might be preferred. Okay. So we've also mentioned a combined endocrine therapy approach for premenopausal. Okay, so that is key here. We are not talking about postmenopausal patients. They would not be candidates for these therapies. This is just premenopausal. And there was 2 major trials, the SOFT and the TEX trial, that were combined and analyzed here. And so these patients received ovarian ablation or suppression with options listed here. The pharmacologic therapy that they used was triptorelin in this particular trial. But often we can extrapolate in practice and use leuprolide or caserelin as options as well. And they combined this with either tamoxifen or an AI, exemestane, for 5 years. Okay, so we said that combined strategy approach really just, when you're doing both of these in combination, 5 years is what the only thing was studied. They did not go out to 10 years here. Disease-free survival, you can see listed here, was very good in these combination arms. So either are options. You can see the numbers are slightly better with the AI combination, but both of these are considered options in guidelines as we've talked through, at the risk of more toxicities. So as you add in ovarian or ablation or suppression, these patients are going to have more toxicity. So that is the risk. So NCCN guidelines, because of the increased toxicities that we see and the fact that these are either a surgical approach or regular injections, they're more burdensome to patients, we would consider this combined approach for patients that are high risk. And what the guidelines call that out is kind of nonspecific, but younger age, patients that have a higher grade tumor or lymph node involvement. So those are some of the high-risk criteria that they say really we should be considering this combined approach, but not 100% necessary, but this is where you would consider it. So our patient case, we went through a patient that would get a combination of an AI plus a CDK4/6 inhibitor with abemaciclib, and that comes from the monarchE trial, and this has really changed a lot about treating early stage breast cancer, and the CDK4/6 inhibitors kind of moving into the early stage setting based on this trial. And I'd like to highlight here the high risk in the title. So this is, again, our low risk patients not going to be candidates. This is just the high risk patient population. This was a phase 3 trial, a large trial. This is hormone receptor positive, HER2 negative. They had previously received surgery, plus or minus radiation, plus or minus chemotherapy in some setting, either neoadjuvant or adjuvant. And they were randomized to standard of care, endocrine therapy for 5 to 10 years, or adding in abemaciclib, and notice here this is 2 years. So it is not the full course of endocrine therapy duration, but just 2 years. And you can see the definitions of high risk here being patients, as we've talked through, with that 4 or more lymph nodes, considered high risk, or if they had 1 to 3 lymph nodes, they had to have another high risk feature, so either a larger size tumor or a higher grade of tumor. And then they added in this second cohort of patients with the 1 to 3 positive lymph nodes that had a high Ki-67 score of 20% or more. And what they found here, we now have 5-year follow-up data, invasive disease-free survival really dramatically improved in the combination arm. So for these high-risk patients, they do appear to benefit when you add abemaciclib for 2 years to their endocrine therapy. These curves, the survival curves, continue to separate with each analysis as we get further out. So it's been really very strong data to support doing this. So the FDA approved the use of abemaciclib in this setting. And again, that high-risk criteria has to be there. And NCCN guidelines really recommend it based on the inclusion criteria of the study. So either 4 or more lymph nodes, like was the situation in our patient case, or if they have smaller number of lymph nodes, they have to have at least one other high-risk feature. Notice there's no mention of Ki-67 score. So this used to be something that was part of the FDA recommendation. They have since pulled back on that because it appears that regardless of Ki-67, if that doesn't seem to really dramatically affect outcomes for patients. So they took that out completely. So there's no mention of that in guidelines or in the FDA approval. Okay, so that was a lot, but that was endocrine therapy. And we said a lot of patients are going to fall into that category. We're going to move on to some discussion of chemotherapy. That's our next kind of part of our roadmap. And you'll notice here, we're kind of breaking it down by what these chemotherapy regimens include. I want to highlight, as we talk about early stage disease, we're talking about combination chemotherapy. Okay, so that's really important here. You'll see that pretty much really everything here is combination chemotherapy approach. Most patients are going to fall into this far right option where you have taxane plus or minus anthracycline containing. So that's kind of the one to star. Most patients are going to fall into one of those categories. And I've noted where there's a preferred designation in the NCCN guidelines. So preferred here being dose-dense AC, so doxorubicin and cyclophosphamide make up AC, followed by a taxane. So paclitaxel, you can see weekly or every 2 weeks can be considered here. Another preferred approach doesn't include an anthracycline, that's TC, so docetaxel and cyclophosphamide. Okay. And then our other preferred option is for a limited patient population. So triple negative breast cancer is where we can add in immunotherapy. So limited use of immunotherapy in breast cancer. So we'll highlight where that is, but this is one of the patient populations, that triple negative patient population where it can be considered. And then you see a number of other options. If patients are not a candidate for a taxane, you might go into this middle category of anthracycline containing. And then if a patient isn't a candidate for either one of those, the anthracycline or the taxane, which is going to be very few patients, but if so, we'll go back to our historical standard of CMF. Okay, so cyclophosphamide, methotrexate, and fluorouracil. So some drugs you don't see often used in breast cancer, but those potential, I've seen in patients, but very elderly patients that are really high risk, still kind of wanting chemotherapy, this might be a regimen that would be appropriate there. Okay, so key points here, generally we're reaching for anthracycline and taxane drug classes. We know that taxanes are highly effective here, so they should be included unless patient has a contraindication. We might do combination of both of these, such as the AC followed by a taxane, for patients that are higher risk features, so larger tumors, lymph node positivity, triple negative, so things that might want us to be more aggressive. Other regimens that we mentioned, TC, so no anthracycline here, because sparing the patient from anthracycline toxicity. That one may be appropriate for a subgroup of patients, maybe lower risk disease or patients that are not a candidate for an anthracycline. So really just risk-benefit analysis when we're considering regimens, but options here and guidelines. Okay, so we're going to move on to another patient case. MZ, 37-year-old premenopausal African-American woman, presents with newly diagnosed right breast cancer, stage 2B, with lymph node positivity. So pathology, she's a nuclear grade 3, so poorly differentiated. You can see she has no expression of estrogen or progesterone, and her HER2 is in a 1+ category, so that's considered negative. So she is considered to be triple negative. She has a high Ki67 at 50%. Notably, she has a BRCA2 mutation, so that becomes important for treatment decision making. She has no additional comorbidities. And the plan here is she's going to get neoadjuvant chemotherapy followed hopefully by a lumpectomy, a surgical resection. So according to guidelines, what is the most appropriate neoadjuvant chemo regimen for our patient MZ? Would you give the CMF regimen? Would you give combination of pembrolizumab plus chemotherapy, so carboplatin and paclitaxel, followed by pembrolizumab plus AC? Would you do dose-dense AC followed by paclitaxel, or AC followed by docetaxel? Okay, great job. So you guys identified that this patient is triple negative. She has a higher risk disease, so she is a candidate for immunotherapy in combination with chemotherapy. This is the only space in early stage where we would use immunotherapy, is right here. So lots of other cancers that you guys have talked about yesterday and today have included a lot of immunotherapy. Breast is just not one of those disease states right now. So very limited space for using immunotherapy, but this is one of them. You could consider other regimens. So you can consider the AC followed by one of the taxane option as the last two. It is not wrong, but you will see as we talk through outcomes, adding immunotherapy really is preferred in these patients because of improved outcomes. And then CMF, none of you chose that. I would argue is a very small patient population where you would forego these other options for that, but technically it could be on the list of consideration. So not totally out of the question. Okay, so really quick back to sequencing, and this slide probably looks remarkably similar to the first one we looked at. What I want to highlight here is when patients have locally advanced breast cancer, so usually larger tumors, lymph node involvement, these are patients that are often going to be candidates for neoadjuvant chemotherapy before surgery. So I just want to point out where that kind of fits in, but sequencing is still very important here. So you'll see the principles of what we talked about in terms of sequencing your chemo first, followed by your endocrine therapy. That still applies, but just highlighting as we add in that neoadjuvant therapy that's going to precede surgery for some of these patients with higher risk disease. Okay, so principles of neoadjuvant chemotherapy. So chemotherapy that we just talked about in the adjuvant setting, those options are really all considerations in the neoadjuvant setting. So make something a little bit easy in breast cancer where we can say what we just talked about applies here too in the neoadjuvant setting. In some patients, you may consider doing neoadjuvant endocrine therapy before surgery. Endocrine therapy doesn't get you a quick response. So I would say this is kind of a limited patient population where maybe they can't get chemotherapy, that you would consider endocrine therapy alone to try to reduce them to get to surgery. If a patient is HER2 positive and they're getting neoadjuvant chemotherapy, you should add in that HER2 targeting therapy with the neoadjuvant chemo. So it should start before surgery. At the time you're starting chemo is when you should add in your trastuzumab plus or minus pertuzumab. And then if we have a planned course of therapy, so example of AC followed by T, we would do all of that before going to surgery. So we don't usually do AC, surgery, T after. So really any planned chemotherapy is going to be given all together in the neoadjuvant setting. There may be the potential to give some treatments after surgery with such things such as residual disease that we'll talk about, but if you have a planned course, then you're going to want to try to get through that before you get to surgery. So candidates for neoadjuvant therapy, we're just going to kind of briefly cover who these are. NCCN and ASCO go into some detail here, but these are generally patients that you can't take to surgery initially. They have inflammatory breast cancer, which is very aggressive. They have, bulky lymph node disease. They have larger tumors where you really need some reduction in disease burden before they can go to surgery to try to get everything out. There's also some data, good data that we have in patients with HER2 positive and triple negative breast cancer. So that second bullet down here on the NCCN side of things, also addressed in the ASCO guidelines, where we have some really great data to help guide us if patients get neoadjuvant chemotherapy and go to surgery. We have some info to guide us on therapies that we can give after the fact based on whether or not they have residual disease. So we're seeing a lot more neoadjuvant chemotherapy for HER2 positive and triple negative breast cancers. And so if they meet the criteria that's listed here with tumor size of greater than or equal to 2 or any positive lymph nodes, those are patients that really should get that neoadjuvant chemotherapy before surgery. I mentioned residual disease. So this is one of the trials that looked at this, the CREATE-X trial. So these patients all had HER2 negative disease. They received neoadjuvant chemotherapy, then they went to surgery. And at the time of surgery, they assessed whether or not, after that neoadjuvant therapy, did patients still have disease there? So if yes, they have residual disease, or no, they had a complete pathologic response. Neoadjuvant chemotherapy wiped out all the disease that's visible. Great. So we know that patients that have residual disease after they get neoadjuvant chemotherapy are high risk for recurrence. Previous to this trial, patients would just, even knowing that, they would just go on to observation. Okay. So this was looking at, can we give additional therapy for those high-risk patients to get better outcomes? So they randomized patients that had residual disease to either get capecitabine in the adjuvant setting for 6 to 8 cycles or control, which was observation alone. And at 5 years of follow-up, they found statistically significant disease-free survival and overall survival for those patients that got capecitabine. Where there was particular benefit was triple-negative breast cancer. So I would note this, that we are currently using capecitabine for patients with triple-negative breast cancer and residual disease. So there was benefit in the overall population, but really where the greatest benefit was in those most highest risks, so the triple-negative patients with residual disease. And so we often see this in practice where we're doing adjuvant capecitabine for those patients. So both guidelines, NCCN and ASCO, recommended in this patient population. Just a note here, the trial used a very high dose of capecitabine. So those of you that have experience with using capecitabine, 1250 milligram per meter squared BID is rough. So guidelines actually recommend that you don't do that you use 1,000 milligram per meter squared for these patients, 2 weeks on, 1 week off. And the trial allowed it to be done in combination with radiation, which was also very toxic. So in using this, the guidelines recommend that you would complete the course of radiation, then do this, so to try to maintain patients on treatment and avoid a lot of the toxicity. So that was chemo. That was kind of our cytotoxic chemo category. We're going to move on to some data with immunotherapy. And as I mentioned, there's not much. So this, I promise, is a smaller category here as we walk through. There's really just one trial, the Keynote 522 trial. And again, if I'm going to highlight anything, we're going to highlight this is triple-negative breast cancer only. Okay? These were patients that had stage 2 or 3 disease, so a little bit of a higher risk with that triple-negative high-risk subtype. These patients were randomized to neoadjuvant chemotherapy, which would be standard of care. They added pembrolizumab to one of the arms, so either chemo alone or chemo with immunotherapy and pembrolizumab. Then patients went to surgery. If they received neoadjuvant pembrolizumab, they got it out back. So they got it in the adjuvant setting for 9 cycles, Q3 weeks for 9 cycles. If they got placebo with their chemotherapy, they went on to placebo in the adjuvant setting. So chemotherapy regimen is listed here. So they did a paclitaxel and carboplatin followed by AC as their neoadjuvant, or EC as an option for patients in the neoadjuvant. So an aggressive chemo regimen for these patients, and did it in combination with either pembro or placebo. PCR rate, so pathologic complete response, was better in patients getting pembrolizumab, and more importantly, disease-free survival at 5 years out, significantly better in the pembro arm. So because of this, we have guideline recommendations to add pembrolizumab to chemotherapy for patients, remember, triple negative, stage 2 or 3. So that is the specific patient population for this chemoimmunotherapy approach. Okay. So another patient case, so we're using these throughout to kind of highlight our major points in breast cancer management. So this is VT, 58-year-old postmenopausal Caucasian woman diagnosed with a stage 3A invasive ductal carcinoma. This patient has triple negative disease. She's germline BRCA1 positive. She got neoadjuvant AC for 4 cycles, followed by paclitaxel weekly for 12 cycles. So this patient would have been a candidate for pembrolizumab chemo we just talked about, but this was actually done before that data came out that she was treated with chemo alone. So after she got her neoadjuvant chemo, she underwent breast-conserving surgery, and she's found to have residual disease in the breast. Okay? So we want to talk about options that we can do. So in addition to radiation, which adjuvant treatment is most appropriate for VT? Would you use ado-trastuzumab emtansine, docetaxel and cyclophosphamide or TC chemo, paclitaxel and carboplatin, or olaparib? Excellent. So correct answer here is olaparib. So I think in terms of that first option, your clue here that the first one is not correct with ado-trastuzumab emtansine. So trastuzumab is a HER2 targeted therapy. This patient has triple negative disease. So she is HER2 negative. You wouldn't use any HER2 targeting therapy in this patient. In terms of our chemo options, docetaxel and cyclophosphamide or paclitaxel and carboplatin, we said that if you're going to give neoadjuvant chemo, you really, with the exception of capecitabine, you're going to give all of that up front in the neoadjuvant setting. So even though this patient had residual disease, we wouldn't give, with the exception of capecitabine, we wouldn't give additional chemotherapy in the adjuvant setting. And then you're correct, we're going to go through the data with olaparib. We're talking about olaparib here because this patient had a BRCA mutation, so that was a very important part of this case. If I had the option of capecitabine, that could also be correct. So what we just talked about with the CREDEX trial could have applied to this patient as well. Okay. So we are going to talk about some of that olaparib data is based on one trial, the Olympia, and this was extended adjuvant olaparib. So it's a phase 3 trial. Patients were HER2 negative with early stage breast cancer. And very important here, they had to have a BRCA1-2 germline mutation, so pathologic or likely pathogenic. variant here. So just to notice, this is germline. They had high-risk features and had received previous therapy with surgery plus or minus radiation and chemotherapy, because this is a high-risk patient population. So standard of care here could have been placebo. We said capecitabine is an option, but at the time this trial was developed, it was not. So that's why they considered placebo here. And then for a year, or randomize patients to olaparib for a year, so BID for a year, with the primary endpoint of invasive disease-free survival. So improvements in invasive disease-free survival, distant disease-free survival, and overall survival. So we now have overall survival data in favor of olaparib for these patients. Okay? So very important to note that we're only talking about patients with germline mutations. So that's where this PARP inhibitor fits in, is for patients with that germline BRCA1/2 mutation. So here is a summary of where this is recommended. So guidelines recommend that adjuvant olaparib for 1 year to start after the completion of chemo. So this is going to kind of extend therapy out for these patients. So after chemo, after surgery and radiation, it is recommended to complete radiation at least 2 weeks prior to initiation because of an interaction between radiation and PARP inhibition. So you want to make sure patients pretty much get everything they were planned, then the olaparib is on the end. So it may also be given concurrent with endocrine therapy. So that's the only thing that could remain. We said endocrine therapy if patients are candidates. That's going to be 5 to 10 years. So that can be concurrent with the olaparib. And the patient population we can use it in is very specific, and this is based on that Olympia patient population here. So after neoadjuvant chemo, if patients have triple-negative breast cancer with residual disease, or we could use it in patients with hormone receptor positive, HER2 negative, with residual disease and the added caveat of this CPS-EG score greater than or equal to 3. I encourage you, if you want to look into that more, you can just Google that and you can find a calculator for that, but that's looking at clinical stage, pathologic stage, their ER status, and their tumor grade all kind of factored in to give a score. So just really trying to get at a higher risk patient. And then after adjuvant chemo, again, looking at these different subtypes, triple negative based on the tumor size, or if they have lymph node involvement, or in the hormone receptor positive, HER2 negative, if they've had 4 or more positive lymph nodes. So I know a lot of specifics here, but I think the important part is we're talking about high risk, we're talking about germline BRCA1 mutation, and we're talking about giving it after the patient's had chemo, surgery, and radiation, and kind of fitting it in on the end there. So next patient case, we're going to kind of shift gears a bit here with patient case HF, 60-year-old female with minimal comorbidities, newly diagnosed stage 3B left breast cancer. Her pathology is ER positive, PR negative, so hormone receptor positive, and she's HER2 positive. So this is the first patient case we've had that's HER2 positive. She's planned for lumpectomy and radiation. But she needs neoadjuvant treatment. She's got a big tumor. So what would be the most appropriate neoadjuvant regimen for HF, given that she's postmenopausal, stage 3B, hormone receptor positive, HER2 positive? Would you choose AC plus trastuzumab for 4 cycles? Would you use docetaxel, trastuzumab, and pertuzumab? THP is another way to say that, times 6 cycles. Or would you do TCH plus pertuzumab for 6 cycles, so that's adding in carboplatin there, or AC times 4 cycles followed by paclitaxel weekly for 12. Okay, excellent job here. So I agree with the majority of you going with the TCH plus pertuzumab, or TCHP is another way you'll see that listed. AC plus trastuzumab. So there's very few definites. Here's a definite. We're not going to use an anthracycline plus a taxane in combination. Cardiotoxicity and cardiotoxicity together. So we would always use those sequentially if patients were going to get them both. So that is why, a primary reason why that first one is wrong. The second option here, docetaxel, trastuzumab, and pertuzumab, would be a great option in the metastatic setting. So we're a little bit more aggressive in the early stage setting, and that's why we're going to add in carboplatin, and that's why that TCH plus P is the option here. So that C is carboplatin in TCHP. So the correct option. And then the last option contains no HER2 targeted therapies. So that's your clue that that one is wrong. Okay, so back to our patient case. She's going to need a trastuzumab-based chemo regimen with or without pertuzumab, although it would be preferred. She's got lymph node positive disease, so preferred here. So after she gets her neoadjuvant TCHP, she undergoes surgery. She has residual disease at the time of surgery. So TCHP did not take care of all the disease that was there. There's some left. So surgery is going to be followed by radiation therapy and adjuvant HER2 targeted therapy. She's also hormone receptor positive, so we want to keep in mind that she also needs endocrine therapy at some point in her course in the adjuvant setting. So which of the following is most important adjuvant HER2 targeted therapy for HF, knowing that she has residual disease? Is it A, pertuzumab, B, ado-trastuzumab emtansine, C, trastuzumab plus pertuzumab, or D, neratinib? Awesome job, Sam. A lot of you answered this pretty quickly here. So the correct option here is ado-trastuzumab emtansine. So again, few definites, but I'll tell you another definite. Pertuzumab monotherapy should never be an option. So if you ever see that, that's always wrong. So that one, none of you chose that, so great job. This patient, the big part of her case is that she had residual disease. So that is what should have led you to ado-trastuzumab emtansine or antibody drug conjugate. We haven't discussed that as an option yet, but we'll get to that soon. Trastuzumab and pertuzumab is an option, not the best option for this patient, but could be considered. And then neratinib is an option in very limited patient population that we'll talk through. Okay, so we're now going to move in our roadmap. We're going to talk a bit about HER2 targeted therapies, and then I promise one slide on bisphosphonates, and then I will give you a stretch break. Okay, so it's coming up here. Okay, so HER2 targeted therapies in the early stage setting. So here is a list of all of our options that can be considered. So notice trastuzumab is our kind of our backbone, our historic drug, been around for a long time. Pertuzumab is another option. It binds to a different epitope of the HER2 receptor. So we said if we're going to use it, we're going to do it in combination with trastuzumab, and we'll talk through that a bit. We also have some sub-Q formulations of this now. So either trastuzumab alone is a sub-Q, or both the trastuzumab and pertuzumab together as a sub-Q formulation. And notice all of those, so the first 4 bullet points here, adjuvant and or neoadjuvant and or adjuvant setting for all of those. Our other options, ado-trastuzumab emtansine, our antibody drug conjugate, just in the adjuvant setting. And then neratinib for a limited patient population in what we call extended adjuvant. So that's where its specific role is that we'll talk through. So a little bit about kind of our historic standards. And we're not going to spend a lot of time here because they have been around forever, and I'm guessing some of you are pretty familiar with these. So trastuzumab is recommended for all patients with HER2 positive cancers that have a 1 centimeter or greater tumor. So again, that's all. So we very rarely say all, but this is really where it was studied, is in patients that had those larger sized tumors. If you remember back to those crazy algorithms we talked about before, you saw a lot of considers in there. So it was really when the tumors were less than 1 centimeter or less than or equal to 1 centimeter that was not very well studied. So you could consider it, but primarily studies looked at the larger sized tumors. Pertuzumab, per FDA label, could be added for tumors that are greater than 2 centimeters or lymph node positive. I will say in practice, if you underline that lymph node positive, that's primarily the patient population where pertuzumab is added to trastuzumab. Preferentially administering these drugs concurrent with chemo. So we know that they're highly effective. You wouldn't want to wait until after chemo's done to start these. We're going to give these at the time that we start chemotherapy. We said with the notable exception of not doing it concurrent with an anthracycline. So if an anthracycline is indicated for a patient, you're going to do it sequentially because of that added cardiotoxicity risk. The standard of care in the early stage setting is 1 year of treatment. So trastuzumab plus or minus pertuzumab for 1 year is considered standard of care. There's been a number of studies that have looked at more or less and kind of still keep landing in this 1 year as being the most effective time frame for patients. And then I mentioned that monotherapy with trastuzumab is not effective, so that should never be a correct answer on any test question. Okay. So somewhat similar slide to what we saw earlier. I'm going to talk just a little bit about the chemotherapy, and this is when we also have that HER2 targeted therapy in combination. So on the left side is the preferred regimen, so that's kind of, those are the ones to star. And this is where you're going to see your options: TCH, TCHP. So adding pertuzumab, we said preferentially those lymph node positive patients is really where that one is probably going to be preferred over TCH. And then in some of our low risk patients, it's possible to just do paclitaxel chemo plus trastuzumab. And it's just in those very small tumors, no lymph node involvement, where that could be considered. And then you see we also have anthracyclines and taxane combinations here with options on the right-hand side. So all of these could be appropriate, keeping in mind spacing out your anthracycline and your HER2 targeted therapy. So residual disease is very important in HER2 positive. We also said it was very important triple negative. So those are the two subtypes where we really want to consider this. So if a patient goes to surgery after neoadjuvant chemo and they have no residual disease, so they have a pathologic complete response, which is great, then at this point, trastuzumab plus or minus pertuzumab could be done in the adjuvant therapy setting. So we want to go out for a total of 1 year, including what was done neoadjuvant. So if the patient had no residual disease, you would want to continue those. So if they started with trastuzumab, probably just continuing that in the adjuvant setting. If you started with trastuzumab, pertuzumab, you're going to do both of those predominantly in the adjuvant setting. If patient had residual disease, this is where that ado-trastuzumab emtansine, our antibody drug conjugate, this is where it fits in. And this is done for 14 cycles. So it would not be appropriate to do this in a patient with a pathologic complete response or no residual disease. It's just that residual disease patient population. If for some reason you have a patient that can't tolerate ado-trastuzumab emtansine, so say you start that, they get 5 cycles in, they're having a lot of toxicity, at that point you could, if you need to stop it, you then switch over to your trastuzumab-pertuzumab combination. So using the antibody drug conjugate, the ado-trastuzumab emtansine, you will also see this abbreviated TDM1. So if you see that, that's the same thing as ado-trastuzumab emtansine. This is based on the Catherine trial. This was really exciting when it came out in breast cancer. So it was a large phase 3 trial, patients that had obviously HER2 positive disease. That's where we're considering this. They received neoadjuvant chemotherapy, which included a taxane and neoadjuvant HER2 targeted therapy, and they had residual disease at the time of surgery. So standard of care at that time would have been trastuzumab as a single agent. So pertuzumab at the time this trial was designed was not routine standard of care, so that's why trastuzumab alone was used here as the comparator arm. Or they gave the antibody drug conjugate, ado-trastuzumab emtansine, for 14 cycles, with invasive disease-free survival as the primary endpoint. And really exciting, you see the hazard ratio there of 0.54, so really impressive improvement in invasive disease-free survival with ado-trastuzumab emtansine. So this was quickly adopted as a standard of care for those patients with residual disease. You can see also has an overall survival benefit. A little bit about pertuzumab. So pertuzumab first was kind of introduced in that neoadjuvant setting, and the question was, does it have efficacy in the adjuvant setting too? And so this was the Affinity trial. So it looked at patients that did not get neoadjuvant chemo. So these patients went right to surgery. Then after surgery, they got chemotherapy plus trastuzumab and either the addition of pertuzumab or placebo. So just looking, does pertuzumab add a benefit in the adjuvant setting in combination with chemo and trastuzumab? And I would say that the results of this trial, I think, were pretty disappointing, the breast cancer world. When you looked, so there was a benefit in invasive disease-free survival, but if you look at kind of the overall population, there was a benefit. But it was very, very small, so 2.6 or 0.9% absolute benefit in the overall population. So 0.9%, not a big difference. But really where it looked to have a benefit when you looked at subgroups was lymph node positive. So again, we're saying trastuzumab really has a benefit in the lymph node positive patients. When they looked at the subgroup with lymph node negative, no benefit with adding pertuzumab. So a lot of that kind of deciding whether to add pertuzumab and looking at lymph node status comes from this trial. No difference in overall survival, but guidelines say to consider it for patients with lymph node positive disease. So I also mentioned a little bit about neratinib in the extended adjuvant setting. So one trial here I want to talk through, that's the ExteNET trial. So this was a trial of patients that, again, had HER2 positive disease, received prior adjuvant trastuzumab and chemo. So they had previous therapy. They had completed their trastuzumab within a year of entry to the study, and they were randomized to neratinib for a year or placebo for a year. So this was patients, they had already gone through chemo, they had already gone through a year of trastuzumab, and it was looking to see if we add another year with neratinib, does this improve outcomes for patients? So just extending that adjuvant therapy with a HER2-targeted TKI, with the primary endpoint of invasive disease-free survival. So they did see fewer disease-free survival events in the neratinib group in the overall population compared to placebo, which was statistically significant. But really when they dug in, they found that the benefit was in patients with HER2-positive disease. So not just hormone receptor positive. So they were all HER2 positive, but the benefit was really in those hormone receptor positive patients. I think a challenge with this trial is it was developed and carried out in the setting before we had pertuzumab and before we had the KATHERINE data with trastuzumab and Tanstine. So now that we're routinely using those drugs in practice, I think it's really unclear how this particular data fits in, but I want to mention it because it is in guidelines, and guidelines state to consider it in patients specific, I would underline, hormone receptor positive. Okay, so our previous HER2 trials we've looked at didn't really call out anything based on hormone receptor status, but this one does. So it's a little bit of a unique thing here in that they call it out for those hormone receptor positive patients that are at high risk for recurrence. So I would say in my practice, I see this used pretty much never, honestly, but it's in guidelines, it's an option, particularly for patients that want to be more aggressive. You could consider this for another year beyond the other therapies we've talked about. If we're going to talk about neratinib, we have to talk about diarrhea because it is very important. So from a pharmacist standpoint, you can see 95% of the patients in the trial had diarrhea to some degree. 40% had grade 3, so a very high percentage of significant diarrhea. You can see the information about median time to onset and duration here. There was a trial, the control trial, which was really important in helping us to understand how to better control the diarrhea for these patients. And what they did here is they looked at either the addition of budesonide, cholestyramine, to loperamide prophylaxis, or a dose escalation. So what came out of this data really was that dose escalation is preferred here. So that's listed here. You start with a lower dose for the first week. You can bump it up a little bit higher for week 2, and then week 3 and beyond, you can go to the full dose. So this is really what's being done in practice to try to help control that early onset diarrhea, is dose escalation. If dose escalation is not used for whatever reason, you want to do scheduled loperamide for these patients. So that is not just having it available and telling them to take it if they have diarrhea. This is scheduled loperamide that PI has very specifics on that schedule. If you do the dose escalation, you don't have to do the scheduled loperamide, but you definitely would want to make sure that the patient has loperamide at home in case it's needed. Okay, so we're rounding out the big bulk of information here. Bisphosphonates, the last thing on our roadmap, and I just want to point out that there is some data in the adjuvant setting with bisphosphonates, so things like zoledronic acid, pamidronate, in using these to actually improve disease outcomes. So they found that the bone recurrence rate was improved, particularly in the postmenopausal patients here, and distant recurrence was improved, breast cancer mortality, particularly in postmenopausal patients. So this is in the absence of patients with bone mets. So we're talking early stage disease, don't have bone mets, that potentially adding in one of these drugs with the bisphosphonate class could improve outcomes. And guidelines suggest that this is something to consider in patients along with the other therapies that we've talked about thus far to reduce the risk of recurrence in postmenopausal patients, specifically postmenopausal, the greatest benefit, with high-risk lymph node negative or lymph node positive cancers. So a consideration here, and what's recommended is zoledronic acid, and this is a 4 milligram dose that's given every 6 months for 3 to 5 years. So that could be considered in adding into the things that we've talked about thus far. Okay, cardiotoxicity. So we're going to talk about this quick supportive care, and then we'll take a break. So HF is planned to receive TCHP for 6 cycles, followed by surgery, and then adjuvant pertuzumab and trastuzumab to complete 1 year of treatment. According to pertuzumab's prescribing information, what is the appropriate frequency for monitoring HF's LVEF, so left ventricular ejection fraction, during neoadjuvant therapy following her baseline assessment? Would you monitor the LVEF every 12 weeks, every 6 months, every 6 weeks, or every 2 months? Okay, excellent. So I agree with all of you. Every 12 weeks is what's recommended in the prescribing information here. So while receiving adjuvant trastuzumab and pertuzumab, this patient's LVEF decreases from her baseline of 60 by 11 percentage points down to 49% via MUGA scan prior to cycle 12. What is the most appropriate action at this time? Would you continue both trastuzumab and pertuzumab? Would you hold both of them? Would you restart the trastuzumab but discontinue pertuzumab? Or would you do the opposite, restart the pertuzumab but discontinue trastuzumab? Okay, excellent. So this patient, we're going to just walk through this briefly, but this patient had a pretty dramatic decrease in ejection fraction, so holding both of these would be an appropriate option here. This is just a brief overview here with trastuzumab. So cardiotoxicity is very important here. Typically, this tends to be a reversible toxicity, so it's something that we want to catch early, make sure we manage appropriately. So baseline assessment is important. You would want to check the patient's left ventricular ejection fraction either by a MUGA scan or an echo scan. I recommend that when you pick one initially, you stick with that same assessment as you move through so that you're comparing apples to apples with assessment. You're not going to be able to adequately compare if you're switching between MUGAs and echoes as you move forward. So you want to monitor this prior to initiation, so get that baseline value every 3 months during or on completion of trastuzumab, and then the PI says every 6 months for 2 years after you finish your trastuzumab. So that's a very difficult thing for patients that have completed really intensive therapy, is making sure that follow-up is done, but that's what the PI has. You would hold trastuzumab for the criteria that's listed here. So a greater than or equal to 16% decrease from pretreatment values, or below the LVEF that's below the institutional limits of normal, and a patient that has a greater than or equal to 10% absolute decrease from pretreatment. So those are the 2 criteria to hold for at least 4 weeks. Reassess. If it returns to normal limits, then you can continue therapy. But there's some criteria to permanently discontinue as well. For patients that are on the combination, so pertuzumab prescribing information addresses the combination because we said you never do pertuzumab alone. So it's always going to kind of look at the combination. So that's where you'd want to go. That's the PI you'd want to go to. So again, baseline assessment. So you see a lot of similarities here. It's recommended prior to initiation and every 12 weeks and that was our patient case here. There's recommendations to hold both of these for at least 3 weeks, and this is a little bit different here. So you see the recommendations differ based on whether the patient has metastatic disease or the patient is receiving it in the early stage setting as either neoadjuvant or adjuvant. So you see slightly different LVEF cutoffs here, but they had to have that cutoff with the addition of a greater than 10% decrease from baseline. So our patient had an 11% decrease from baseline. And then resumption criteria is listed here. Okay. A brief mention of anthracycline cardiotoxicity. So I'm sure many of you are familiar with this as being a side effect of anthracyclines. You could see these different categories as either acute, chronic, or late onset. One of the big differences, we just talked about HER2 targeting therapies with cardiotoxicity being reversible. This may be irreversible toxicity, so really important to note, especially from a monitoring perspective. You can see the differences here. Acute usually is occurring pretty frequently. It's uncommon to see that. Chronic is what we're more likely to see if it's going to happen, and is related to cumulative dose that we'll talk through. And then late onset, particularly in a pediatric patient population, is of big concern. Risk factors are probably what you expect, with a lot of just cardio risk factors that we would see. A couple that I want to call out is patients that have low normal ejection fractions at baseline, so that 50 to 54% being higher risk, and also those with high cumulative anthracycline doses. So we know it's important to look at that cumulative anthracycline dose, definitely a testable thing here. So the greater the cumulative dose, the higher the risk of developing cardiotoxicity. Dexrazoxane, who probably remember this, has mentioned something with extravasation here with anthracyclines. It also can be used to prevent cardiotoxicity. So it's considered for use in patients specifically metastatic breast cancer. Okay, so that is where it might be considered, who are receiving doxorubicin-containing chemo and have received at least 300 milligram per meter squared by bolus, so a higher risk for cardiotoxicity based on that cumulative dose. It is not recommended in the adjuvant setting due to some concerns that it may impact efficacy of treatment. You see, dosing is based on a ratio, so it's done 10-to-1, dexrazoxane to doxorubicin. You want to administer immediately prior to doxorubicin. And then there's not a lot of information about using it with other anthracyclines in terms of that ratio, but that 10-to-1 may be also appropriate with epirubicin. I think you will find this content to be a little bit easier. I do from a teaching standpoint and from a learner standpoint, in talking a bit about kind of understanding some of the principles of the metastatic disease setting. So we are, in this part 2, we're going to talk about where our pharmacotherapies fit in with the metastatic setting. So again, endocrine therapies, chemotherapies, and we're really going to focus in on a lot of targeted therapies that we didn't discuss previously. And then we're going to wrap up with a few supportive care topics with some bone mets supportive care and also a few survivorship issues. Okay, so a big difference as we switch gears here to the metastatic setting is that our goals of care are changing here. So we are talking for patients about a palliative intent of our therapy. We're trying to prolong survival, enhance quality of life for patients. So quality of life is extremely important and is now an endpoint in a lot of the studies that we're seeing come out with breast cancer data. The site of metastases is important as we kind of get to understand the prognosis of the disease. So majority of patients will have bone mets. It is a place that breast cancer likes to metastasize. Patients with bone-only mets tend to have more indolent disease course. If they're hormone receptor positive, they tend to respond well to endocrine therapies. Those patients with visceral or soft tissue mets, particularly those patients with symptomatic disease, tend to have more aggressive disease, and chemotherapy may be needed in some of these patients to control symptoms. It is standard of care to biopsy recurrent disease whenever that is possible. So a patient that may have been initially treated in the early stage setting, we had a biopsy, we understood the hormone receptor status, the HER2 status, We want to rebiopsy in the metastatic setting for those patients that develop recurrent disease. Sometimes the pathology results are not consistent with what was seen initially. So you don't want to make an assumption that that disease is still hormone receptor positive or HER2 positive, for example. So rebiopsy is important to be able to look at those pathologic features again and make decisions about treating in the metastatic setting, because it may not be what you're expecting as what maybe patients had in the early stage setting. Along with that biopsy, it's important to look at biomarker testing here. So we talked about a few testing things that are done in the early stage disease, but you're going to see more here in the metastatic setting. So you see a listing based on subtype in the guidelines and what biomarker testing is recommended. So for all subtypes of disease, so regardless of hormone receptor or HER2 status, we're going to check things like for a BRCA1/2 mutation, MSI high, tumor mutational burden, for an NTRK fusion or a RET fusion. So some of these are very rare in breast cancer, but it's recommended just to get that full panel to be able to assess for any of these. Particularly for patients with hormone receptor positive, HER2 negative, you're going to be looking for things like a PIK3CA activating mutations or an AKT1, PTEN alteration, an ESR1 mutation. So we'll talk a little bit about why we care about those things and what we can do from a treatment standpoint. And then for triple negative breast cancer, we care about PD-L1 expression. So we haven't cared about PD-L expression thus far. When we talked in the early stage setting about that KEYNOTE-522 trial, when we added pembro to chemo, remember that we didn't talk about patients being PD-L1 positive or PD-L1 negative because it didn't matter. All of those patients benefited from pembrolizumab in the early stage setting. It is a different story in the metastatic setting, so we'll get to that. So that's why we care about PD-L1 expression here. So decision making in the metastatic setting does have some similarities to what we talked about. Okay, so you don't have to throw out everything you learned. So we still care about hormone receptor status. We still care about HER2 status. One other decision maker that we need here is knowing whether a patient has extensive or symptomatic visceral mets or not. Most patients will not. Okay, so we're going to start with actually the minority that do have that extensive or symptomatic visceral involvement. And we'll talk about kind of how it's a little bit different from how we treat patients that don't have it. So you'll see regardless of their hormone receptor status, so positive or negative, you'll see that endocrine therapy is not listed here. And that's because, as we said earlier, endocrine therapy is sort of slow to act. It works well, but it takes a while to get that effect. So in these patients that have symptomatic high burden disease, it is standard to give them chemotherapy initially to decrease the disease burden. So even if they have hormone receptor positive, chemotherapy initially to decrease disease burden. And then we can kind of treat from there. Once they are asymptomatic, decrease that disease burden, we can kind of treat with the next algorithm that we'll show. But initially, these patients are all candidates for chemotherapy. And then, as makes sense, if they have HER2 positive disease, we're going to add on HER2 targeted therapy. If they don't, it's going to either be chemotherapy alone with or without the addition of pembrolizumab. So you see here specifically in that patient, that triple negative patient population with a PD-L1 combined positive score of greater than or equal to 10. So it's a very specific patient population that we would add pembrolizumab to chemo. Okay? So important to know, chemo is our backbone across the board with these very symptomatic patients. For patients that don't have that symptomatic high tumor burden, which we said is most patients will fit here, then we're going to be looking at the things that we've been looking at all along. So we're going to look at the hormone receptor and the HER2 receptor status. And just to kind of walk through these, because this is an important foundational slide as we move forward. So for those patients, first we're going to look at hormone receptor positive on the left-hand side. So if they're hormone receptor positive and HER2 positive, this is a bit of a gray zone in that we have options. So knowing that they're HER2 positive, that is a little bit more aggressive disease. So it is potential to give these patients chemotherapy with that HER2 targeted therapy. And you could do that up front, or you could just do your endocrine therapy with your HER2 targeted therapy and kind of forego the chemo. So it is a possibility to kind of do both of those options, and that's going to be a patient-specific decision that you would make. It is possible in those patients that if you do choose to give chemotherapy up front, that after they get a course of chemotherapy, kind of backing off on the chemo to decrease toxicities and then going to your endocrine therapy with that HER2 targeted therapy is an option. Sticking with the hormone receptor positive, if they're HER2 negative, okay, this is where we have most of our patients that fit into this particular subtype. You'll see endocrine therapy because they're hormone receptor positive, and you see plus or minus targeted therapies. Most of the time, this is going to be plus targeted therapies. And so we'll talk through that a little bit more, but definitely a lot of targeted therapies we've had added here. If patients have hormone receptor negative disease, as you would expect, no endocrine therapy on the right-hand side of the screen here. If they're HER2 positive, it's going to be chemo plus your HER2 targeted agent. And if they are not, so HER2 negative, that would be your triple negative patients. Chemotherapy is your backbone, and then you also see that plus or minus pembrolizumab for those patients with that particular, the CPS of greater than or equal to 10. You also see the caveat, for those select patients that have the germline BRCA1/2 mutation, across the board here, one of our PARP inhibitors is an option for those patients. So we have two here. Early stage, we just talked about olaparib. Here you also see we have the addition of talazoparib. So either one of those PARP inhibitors is acceptable in the metastatic setting. Okay, so another patient case. This is CG, 67-year-old postmenopausal female with a 1.7 centimeter right breast mass detected on mammogram. Biopsy reveals that this patient has hormone receptor positive disease, HER2, so you'll see HER2 2+ by IHC, negative by FISH. So this is ultimately this is a HER2 negative patient based on that. This patient is complaining of back pain, so they do some additional workup and the patient's confirmed to have bone mets by bone scan. So what treatment is most appropriate for CG's newly diagnosed metastatic disease? Is it A, ribociclib plus letrozole, B, elacestrant, C, alpelisib plus letrozole, or D, fulvestrant? Okay, I like where you guys are at. So option A is correct, ribociclib plus letrozole. So thinking back to our algorithm, this patient does not have very symptomatic visceral disease, so she just has bone mets that we know of. This patient would be a candidate for endocrine therapy because she's hormone receptor positive. And then we have options of targeted therapy, so we're going to talk through what those are, but a CDK4/6 inhibitor with ribociclib added to an AI as endocrine therapy backbone would be appropriate here. Elacestrant, none of you chose that, and that is appropriate. This patient doesn't have a particular mutation called an ESR1 mutation that would be needed for that drug. Alpelisib plus letrozole, this patient does not have a PIK3CA mutation. Okay, so we'll talk through that nuanced part of treatment. And then fulvestrant, I would say, is an option for this patient, but only in a patient that couldn't tolerate a targeted therapy like the CDK4/6 inhibitor being added to endocrine therapy. So endocrine therapy alone is really just for those patients that you're not able to give a targeted option. Okay. So this patient fits in, we said in our algorithm, fits in right here is that endocrine therapy plus or minus targeted therapy. But you'll see in guidelines the plus targeted therapy is really where the majority of patients fall. So she was treated with ribociclib plus letrozole for 2 years. Repeat CT scans at that time showed that her disease is progressing and she has new lung mets. So repeat pathology, say rebiopsy is done at that point. She still has hormone receptor positive, HER2 negative disease. This patient has an ESR1 mutation. She also is found to be PIK3CA negative and is germline BRCA negative. Okay, so we want to look at what second-line treatment option is most appropriate for CG. Would you choose fulvestrant, alpelisib plus fulvestrant, C, olaparib plus elacestrant, or D, elacestrant alone? Excellent. So the correct answer here is elacestrant alone. Fulvestrant is, for this option, probably not the best for this patient. We know that she has an ESR1 mutation. So there is a trial that we're going to go through that will tell you that when they compare these two, elacestrant did better. So that's going to be preferred for her. She does not have a PIK3CA mutation, so that second option with alpelisib and fulvestrant is not on the table for her. And then olaparib and elacestrant, not a recommended combination, first of all, and she also does not have a germline BRCA mutation to be eligible for a PARP inhibitor, so kind of twofold reason for that one. Elacestrant is correct as a single agent. So this is a very important slide. This is one I would definitely star in your notes. We said most patients will fall into this category, the subtype of hormone receptor positive, HER2 negative. And so this is really kind of a guideline for what our options are in guidelines for treatment of these patients. When we look at that first column, the preferred first-line strategies here, you see that this is that targeted options plus endocrine therapy. So targeted options here being a CDK4/6 inhibitor in that first-line setting. So you can combine that with your endocrine backbone with either an AI or fulvestrant. Okay, so any of the CDK4/6 inhibitors could be an option here. But notice that there's category 1 for a couple of agents, and this relates back to some of the trials have shown an overall survival benefit with the CDK4/6 inhibitors, and some of them haven't. So they all remain an option in guidelines, but there's a preference for certain drugs based on where we saw the overall survival benefits. So you see that AI plus ribociclib having that category 1 recommendation if we're going to use an AI endocrine backbone. And if you're using fulvestrant as your endocrine backbone, either ribociclib or abemaciclib both have category 1 recommendations as the CDK4/6 inhibitors here. So I would just, in terms of choosing an AI versus fulvestrant, AI being oral continuous therapy, CDK4/6 inhibitors being oral therapies. So it's an easy all-oral regimen for patients. I would say if we have the opportunity, that tends to be the one that's chosen here. Fulvestrant, again, we see it's also an option. It is, for any of you that are aware of this drug, it is a very difficult IM injection in the gluteal muscle. It requires 2 separate injections. It's a very viscous solution, so just a very uncomfortable injection for a lot of patients. So it might be a reason why, if you can do an AI, you're going to go the AI preference. But I would say for patients that maybe progressed while on an AI in an earlier line, say in the adjuvant setting, or maybe patients that progress shortly after an AI, you may want to go to your fulvestrant option here. We also see the preferred second and subsequent line. So in the middle column here, we have options. This first one with the CDK4/6 inhibitor plus fulvestrant is probably not used in practice very often anymore because of the fact that we're doing so much CDK4/6 inhibitor in the frontline setting. Very few patients fall into this if they didn't use it previously. So there are very few patients that will probably get that in the second line setting because they've already had a CDK4/6 inhibitor. And then we have some very specific biomarker-driven therapies. We have alpelisib plus fulvestrant, so it's only studied with alpelisib with fulvestrant combination for those patients with a PIK3CA mutation. If brand new to the breast cancer treatment option is an oral drug called capivasertib, plus in combination with, again, with fulvestrant. This is a little bit more broad, so it's still got a specific biomarker, so either the PIK3CA or an AKT1 PTEN activating mutation. So you have to have one of those to qualify for this drug. And then our last option here, everolimus plus endocrine therapy, that has been an option for quite some time now in breast cancer. So we're not going to really review the data here. Based on the Bolero-2 trial, was the big trial here, endocrine therapy can be a number of different options you see listed. This is not biomarker driven, so this could be an option for patients that don't have any specific biomarkers that we can use other therapies. And then you see the third column, and this is really our endocrine-only approaches. So for select patients maybe that aren't candidates for some of these targeted therapies, in addition, you would consider these. You see very specifically elacestrant called out for those patients with ESR1 mutation. So some specifics here on that. So this is kind of going to be an important slide as we move forward. One other call out here is these are options we have for pre and postmenopausal. But if a patient is premenopausal, you're going to need to add on something for ovarian suppression or ablation. So either they need to have removal of their ovaries, or you're going to need to give them something like goserelin, leuprolide, triptorelin, so one of our LHRH agonist agents to shut down ovarian production of estrogen in combination with these. So you would do these strategies plus one of those other agents. Okay, a little bit more detail about elacestrant because it is newer to the market. So I'm going to provide just a little bit more detail. Prior to this, our only option that fell into that SERD category, so selective estrogen receptor degrader, all we had was fulvestrant, that we said is an IM injection, not very patient-friendly. So this is an oral SERD option. So what it does, it's an estrogen receptor antagonist, so it goes to the estrogen receptor at the level of the breast cancer cell. It binds to that and it breaks down the estrogen receptor. So indicated here for postmenopausal women or men with estrogen receptor positive, HER2 negative, key here, ESR1 mutated, advanced or metastatic breast cancer who have received prior endocrine therapy. They've now progressed through that endocrine therapy, so they need another option. So really the key here being the ESR1 mutation to help pick out patients that are eligible for this treatment. It's a daily PO medication that should be taken with food. You see side effects listed there, probably not really uncommon for oral oncologic drugs with some GI side effects listed, but you also see increased cholesterol and increased triglycerides as problematic with this agent, so things to consider monitoring. The approval here was based on the EMERALD trial. So this was a phase 3 trial in this patient population we've been talking about. So hormone receptor positive, HER2 negative. They had to receive at least 1 to 2 prior lines of endocrine therapy for advanced disease. So they were pre-treated patients. And they received prior CDK4/6 inhibitor and could have received up to 1 line of chemo. So they didn't have to receive chemo, but they could have. And they were randomized to elacestrant or standard of care endocrine therapies. This was either our IM SERD with fulvestrant or an AI. And so what we're seeing here is there was a benefit across the board with all patients, but the benefit in terms of that progression-free survival was really most significant in patients with an ESR1 mutation, which is about half of the patient population here. So the FDA approval and the guideline recommendation was specific to those ESR1 mutated patient population. No overall survival benefit to date, but we'll await more data there. Okay, just a little bit about from the ASCO guidelines. These are kind of ancient at this point in terms of breast cancer, how quickly breast cancer data changes. But just a little bit here with principles of treatment. Some of this I think will make sense here, that tumors that express any level of hormone receptor, so any degree of ER or PR, should be offered endocrine therapy that continues until disease progression. Combining chemo and endocrine therapy is not recommended. I sometimes see it in practice in the metastatic setting. It is like a hard no in the early stage setting, I would say. In the metastatic setting, sometimes we consider it, but I do want to call out from guideline practicality, the recommendation is no. Chemo may be needed for these patients if we said they have that symptomatic visceral disease where you need a quick response. And that, as makes sense, we would add HER2-targeted therapy for patients with HER2-positive disease. That can be added to endocrine therapy, or they can be added to chemotherapy. We said that was kind of a gray zone. Okay. A little bit about CDK4/6 inhibitors. They're incredibly important in metastatic breast cancer treatment. have really changed a lot about the way we treat the majority of patients in this setting. So we have 3 options here: palbociclib, ribociclib, and abemaciclib. Guidelines support any of these used in combination with endocrine therapy, so an AI, or we said fulvestrant is another option, in first line, which is primarily where we're doing it, or potentially in subsequent lines if patients didn't see a CDK4/6 inhibitor previously. We did say that there was, in the guidelines on that starred slide I know you guys have, we did say that there was some category 1 preferences that we pointed out, and I said that was based on overall survival data. So we're going to quickly walk through the trials. There are a lot of them, so I'm going to do kind of the high-level summary of what I think is most important here. The palbociclib trials were the PALOMA trials, so PALOMA 2 and 3. And you'll see here that across the board, as we talk through all of these CDK4/6 inhibitor trials, there's a lot of similarities. So all of these patients were hormone receptor positive and HER2 negative that had advanced or metastatic disease. All of these CDK4/6 inhibitors were looking at in combination with endocrine therapy or in combination with placebo. So you see different endocrine therapies used, but all used them in combination with endocrine therapy. You'll see slightly different patient populations that are called out here. So a lot of them including postmenopausal patients. And then either in the first line or some trials that looked in second or subsequent lines of therapy. So some slight differences here, but a fairly similar patient population. And what we saw in these trials is that progression-free survival with the addition of the CDK4/6 inhibitor dramatically improved compared to that endocrine therapy plus placebo. So doubling in a lot of these arms of that progression-free survival with very similar hazard ratios. Overall survival, I would like to just point out with the PALOMA trials, they did not reach statistical significance with overall survival, so we don't have that overall survival with any of the palbociclib combinations. So again, it's in guidelines, it's an option for our patients. It didn't get that category 1 recommendation, but it could still be considered. MONALEESA trials were our ribociclib trials. So again, I'm not going to go through all of this, but very similar patient population to what we just pointed out. Also looking at it in combination with endocrine therapy. I do want to point out MONALEESA 7 only included premenopausal. So it's the only CDK4/6 inhibitor trial that had exclusively a premenopausal patient population. Again, you see very good progression-free survival with similar hazard ratios across the board. And I highlighted these overall survival boxes in red because they were all statistically significant. So the ribociclib improved overall survival in all of these 3 trials in combination with AI, fulvestrant, and in both pre- and postmenopausal patient populations. One quick call out with MONALEESA 7, because it was in a premenopausal patient, they did include tamoxifen as an endocrine backbone here. It is not recommended to use tamoxifen in these patients because of a concern for QTc prolongation with ribociclib and kind of additive with the tamoxifen. So that is not recommended even though this trial did that. So in that premenopausal patient, remember that we would need to add in our OAS. Okay, so something to shut down ovarian production of estrogen is going to be really important here. Okay, and then finally, our last CDK4/6 inhibitor to touch on is abemaciclib. You are aware of this drug because we talked about that as the only CDK4/6 inhibitor in the early stage. So now it makes its appearance in the metastatic setting in the MONARCH trials. Again, very similar patient population, similar trial designs. One thing to call out here, the MONARCH 1 was a very different trial. So this one, very different from everything we've talked about. This was looking at single agent abemaciclib, no endocrine therapy backbone, in a very refractory patient population. Had received previous lines of endocrine therapy, chemotherapy, and this was kind of, there was no other good option for these patients. Can we give them single agent abemaciclib? At the time this trial was done, CDK4/6 inhibitors were novel agents, so they didn't receive them in earlier lines of treatment. And they did see an improvement, or they did see about a 20% overall response rate here. So it is an option, but very few patients would meet this criteria anymore because we're giving CDK4/6 inhibitors in standardly in first-line or potentially second-line treatment. Monarch 2 trial, in addition to the progression-free survival, did have an overall survival, so that's why you see this one highlighted in red. And just recently at the San Antonio Breast Cancer Symposium in December, we found out that the final OS analysis that was done on the Monarch 3 trial did not reach statistical significance. So numerically improved overall survival benefit that is fairly consistent with other trials we've seen with CDK4/6 inhibitors, but did not reach that statistical significance. So it's across the board, knowing that progression-free survival was improved in all of these trials. Standard of care to add these drugs to endocrine therapy because of that, and select trials had an overall survival benefit while others didn't. One drug that we mentioned earlier is alpelisib. We said that that's given in combination with fulvestrant. That is based on the SOLAR-1 trial, and this, again, a large phase 3 trial of patients that were given alpelisib plus fulvestrant versus placebo plus fulvestrant. And what you can see here is that for patients with the PIK3CA mutation with this bar graph, those are the patients that really had that improved progression-free survival with the combination. For those patients that did not have that mutation, you can see the dark blue and the light blue bars are fairly similar there. So really no benefit in patients that don't have that PIK3CA activating mutation. No overall survival benefit with this combination, but based on that progression-free survival benefit, it's listed as an option in guidelines for patients specifically with the PIK3CA mutation after progression on other endocrine therapies. So that's why you see it in the second line setting or beyond. And definitely some significant adverse effects. The one to call out, definitely keep in mind, is hyperglycemia with alpelisib. Our other drug that works similarly, just a little bit more detail with this one because this is the newest addition to breast cancer treatment options. This is capivasertib. It inhibits AKT 1 through 3. It is also indicated in combination with fulvestrant in that same patient population who have received previous lines of endocrine therapy. So you're not going to use this in the first line setting either. The difference here is that it's not just the PIK3CA mutation, but also includes patients that have an AKT1 or a PTEN alteration. So it expands options a little bit more. Interesting to call out the schedule here. So an oral drug that's BID, 4 days on, 3 days off until progression. So definitely a lot of need for patient counseling on that schedule. And then toxicities, somewhat similar to alpelisib in that you also see here increased glucose as being a concern, diarrhea, cutaneous toxicities, and stomatitis is another one to call out here as being important to watch for. This was based on the Capitello 291 trial, so a newer trial that was just published in New England Journal towards the end of last year. A larger trial, again, the same patient population we've been talking about who have progressed on prior treatment with endocrine therapy with an AI plus or minus CDK4/6 inhibitor. So they gave capi plus fulvestrant or placebo plus fulvestrant. About 40% of these patients did have that AKT pathway alteration. And you could see improvements in kind of the overall population, the patients that didn't have that AKT alteration, but you see a more significant improvement in patients that did have that AKT alteration. So the FDA approved it just specifically for those alterations or mutations that we mentioned before, and that's where guidelines also recommend this combination. Okay, so that was a lot here, but we're gonna switch gears a bit, and we're gonna talk about patients that either have that visceral crisis, so endocrine therapy up front isn't going to be your best option, or in patients that have now become endocrine refractory. So notice here, there are no endocrine options listed because of those reasons. And so just breaking it down based on guidelines in that first line setting, it's really your determination for treatment is whether or not the patient has a germline BRCA mutation. So as you would expect, if they have that, we have the option of a PARP inhibitor. So we said we have two here, olaparib or talazoparib. If they do not have that, then chemo is your backbone. In the second line setting, you're now going to see our options for some antibody drug conjugates. So if patients meet criteria for something called HER2 low, that we'll talk about shortly, they're a candidate for something called famtrastuzumab deruxtecan, You also see that TDXD as the abbreviation for that. If they don't meet that HER2 designation, another option could be another antibody drug conjugate, sacituzumab govitecan, or systemic chemo options. In the third line setting, systemic chemo would be your consideration, or if they had any particular biomarkers that could be targeted, any of those tumor agnostic indications, we could use those. So we're going to move on. Patient case BZ, 50-year-old postmenopausal female who presents with jaundice, dyspnea upon exertion, and fatigue. She has breast cancer that's metastasized to her liver and lung. You see her pathology here. She is triple negative, PD-L1 negative. She is BRCA2 positive. Okay. So in terms of these patients with triple negative disease, so we're going to get to the audience response question shortly, but just going through this in a little bit more detail. Again, triple negative, no endocrine therapy listed here for obvious reasons. In the first line setting, there's now two factors we want to look at. Germline BRCA mutation status and their PD-L1 CPS score. So if they have a high CPS score of 10 or higher, even if they're germline BRCA positive, guidelines said pembro plus chemo should be what you go to first. If they don't make that criteria for that pembrolizumab chemo combination, so CPS less than 10, we're going to be looking at that germline mutation status, that BRCA status, to tell us what to do. If it's positive, we can use a PARP inhibitor or potentially platinum chemotherapy for those patients. And if they don't have any of those options, then systemic chemo we're going to reach for. Second line setting, if they have a germline BRCA mutation and we didn't use a PARP yet, we can go there. If they have any kind of biomarker here, sacituzumab govitecan is an option, or chemo in the second line setting. If they don't have a germline BRCA mutation and they're HER2 low, so HER2 low being this antibody drug conjugate, the famtrastuzumab deruxtecan. And then once we get to later lines of treatment, it's going to be systemic chemo as your backbone, and then if we have a biomarker to target, we will. So now we're going to go back to BZ. Remember, she was postmenopausal, she was triple negative. She did not have CPS score of 10 or higher, so it was lower. And this patient has a BRCA mutation. So would you recommend A, rucaparib, B, talazoparib, C, gemcitabine, or D, doxorubicin? Okay, excellent job. So we said talazoparib is our PARP inhibitor of choice here. Rucaparib is not used in breast cancer, so that would not be appropriate. And I would say because she is BRCA positive, I would reach for a PARP inhibitor before we would go to chemo options with gemcitabine or doxorubicin. Okay, so a little bit more about our PARP inhibitors. We've talked about these quite a bit, so we won't spend a lot of time here, but these are particularly for patients with that germline BRCA1/2 mutation, used as a single agent. We have our two options listed as oral agents. And these are based on two similar trials, the Olympiad AD and the Embraca trial. So these were comparing PARP versus single agent chemo, which was standard of care prior to these trials. You can see that progression-free survival benefit with similar hazard ratios with both of these trials, and then no overall survival benefit here in terms of no statistical significance. Improved quality of life with PARP inhibitor, so improved PFS and improved quality of life. So that's why we're going to be going for a PARP over chemo whenever possible. And really no, other than some slight different side effect profiles, really from an efficacy standpoint, no preference for olaparib versus talazoparib. Okay, so our patient fits into this kind of the bottom part where we said the patient has a BRCA mutation, we'd reach for one of the PARPs. Chemo for metastatic disease. So a couple things here. We said early stage, it's combination chemo. Late stage, we're mostly going for single agent chemo, trying to maintain good quality of life for our patients. We're going to be doing chemo up front when we can't do endocrine therapy. Okay? And also, we said for those patients that have a lot of symptomatic disease burden. We said preference for single agent for most patients, combination for some patients if you're maybe noticing they have very aggressive disease and you want to get a quicker response, that could be an option, but important to know single agent is kind of the backbone of what we're doing, continued until progression. So here are some of the options. You see, agents I'm sure you recommend with our anthracyclines, taxanes, antimetabolites. Options for our platinums for a particular patient population, triple negatives, and germline mutations. You see other options, these are considerations. So what we saw previously was preferred. These are kind of things you can consider. Also see that there's combinations listed, but we said not a preference for combinations for most patients. Okay, a little bit about our Pembro plus chemo. That was based on the Keynote 355 trial that looked at this. This is first-line setting for patients with triple-negative breast cancer. And they were randomized to chemo alone or the pembrolizumab plus chemo options. You could see the backbones listed there. So nab-paclitaxel or paclitaxel, or they allowed the combination of gem carboplatin. So the improvement was seen in patients with that CPS greater than or equal to 10, which is where that fits in as we've talked about. So improvement in progression-free survival and overall survival in that patient population. When CPS was looked at kind of all comers of greater or equal to 1, there was no improvement. So it appears to be those patients with a higher CPS score that benefit. In terms of that immunotherapy, kind of as an overview, pembrolizumab plus chemo option is preferred for first line for those patients with a higher CPS score, determined by that 22C3 antibody assay. Originally, as some of you may remember, atezolizumab was approved in breast cancer, and that was withdrawn. The confirmatory trial did not show a benefit, so that approval was withdrawn. Duration of chemo really is until progression or prohibitive toxicity for our patients. So usually treatment is going to be continued for the long term. I mentioned an antibody drug conjugate with sacituzumab govitecan. So I want to just mention 2 quick trials here that led to the approval of this agent and using it both in triple-negative breast cancer, which is the ASCENT trial, and also in very refractory hormone receptor positive HER2-negative, which is the next trial we'll talk about. So this is an antibody drug conjugate. The antibody here is a TROP2 antibody that is expressed on many breast cancer cells, so we don't test for TROP2. And then govitecan is a topoisomerase 1. It is SN38. Some of you may remember the active metabolite of irinotecan is SN38. So if you think of irinotecan toxicities, they are very similar with this agent. So neutropenia and diarrhea being 2 big ones that we see here. So this was a patient population that, again, triple negative, received previous lines of treatment in the metastatic setting. So they had received at least 2 previous lines of treatment, and they were randomized to either this agent, it's given IV 2 weeks on, 1 week off, or physician's choice of chemotherapy that you can see listed here, single agent chemo. And this is a heavily pretreated patient population, so a median of 4 prior lines of treatment, improved progression-free survival and overall survival in this patient population. So that's kind of where it's landed. We wouldn't use it first line, but a consideration in second line setting and beyond for those triple negative patients. I mentioned that other trial here, different patient population. So this is the TROPiCS-02. This is a very refractory hormone receptor positive HER2 negative metastatic population. They had received 2 to 4 prior lines of chemotherapy for metastatic breast cancer and had received prior taxane, CDK4/6 inhibitor, and endocrine therapy. So they had gone through a lot of lines of treatment. And they were randomized here to same thing, sacituzumab govitecan or physician's choice of chemotherapy. And what was found here is an improved progression-free survival and overall survival. So both of those endpoints improved in this refractory patient population. So we're going to move on to another patient case, GS, 62-year-old postmenopausal woman. She initially was diagnosed with an early-stage breast cancer, hormone receptor negative, HER2 positive, treated with surgery, adjuvant chemotherapy that's listed there with trastuzumab, followed by radiation, and then trastuzumab to complete 1 year of treatment. She presented 1 year ago with metastatic breast cancer to the bone and lung. They did another biopsy, and it's consistent with that original pathology. So she receives first-line THP, so docetaxel, trastuzumab, and pertuzumab for 6 cycles, followed by trastuzumab and pertuzumab maintenance, and she now has disease progression with lung mets. So which of the following regimens is most appropriate for her in the second-line setting? Would you choose neratinib and capecitabine, fam-trastuzumab deruxtecan, trastuzumab and lapatinib, or ado-trastuzumab emtansine. All right, excellent job. So I agree with the option here of fam-trastuzumab deruxtecan. Our historic standard was the ado-trastuzumab emtansine. We now know that there is improved efficacy with fam-trastuzumab deruxtecan, so that would be preferred. Neratinib and capecitabine and the trastuzumab lapatinib combinations are options, but in a more refractory patient population. So I would say that those have moved really to kind of third line and beyond. Okay, so our patient fits in right here in our algorithm where we're considering chemotherapy and HER2-targeted therapies. So just a refresher, we saw a similar slide in the early stage setting. We've now, in the metastatic setting, have expanded our options. So we have more TKIs listed here with, you see, lapatinib and tucatinib, and you also see that trastuzumab deruxtecan option, another antibody drug conjugate that's been added as an option. For those patients that are HER2 positive and hormone receptor positive, some of them may be candidates for endocrine therapy without chemo. So we said that that was an option added to our HER2 targeted agents. So you can see options here. Just want to point that out is here there are options that exclude chemotherapy that can be considered in select patients. Chemotherapy-wise, I love to be able to say from a learning perspective, in the first-line setting, there's one option. So something that really, like truly, you could say this is right, at least as of right now in the first-line setting. So that was that THP combination. So pertuzumab and trastuzumab with a taxane. Docetaxel was the one that was most well-studied, but paclitaxel is also an option. So patients in the first-line setting, that is what's recommended. If there's progression on that in the second-line setting, our option here was correct. You picked out for our last patient case, fam-trastuzumab deruxtecan. And then once we get to the third-line setting or beyond, you really do see that the options expand a bit. So tucatinib, trastuzumab, and capecitabine, so a triplet regimen here. You may see some preference for patients with bone mets. I'm sorry, not brain mets here. So highlighting kind of that CNS benefit here in CNS disease. And then our other antibody drug conjugate, ado-trastuzumab emtansine, can be considered. And then lots of options I'm not going to talk through in the fourth-line setting. But notice that they all include a HER2-targeted agent with another backbone. And so this is where neratinib and capecitabine fits in. Margetuximab is another monoclonal antibody that can be considered here in combination with chemo. A little bit about fam-trastuzumab deruxtecan. So there are the Destiny breast trials that have really changed treatment here. So quickly, Destiny Breast 03 was looking at it in the second-line setting. So patients that had previously received THP that had progression, and they were randomized to one of these two antibody drug conjugates. They found improved median progression-free survival with trastuzumab deruxtecan and overall survival benefit. So just to call out, ILD is an important adverse effect to monitor for, particularly with the trastuzumab deruxtecan. So that, very kind of testable question as you look at adverse effects of that agent. Destiny Breast 01, I'm just going to highlight that this was the first trial that came out with this agent and looked at a very refractory patient population, so it's since moved up in lines of treatment. And you heard me mention just a little bit with margetuximab plus chemotherapy. So it's another monoclonal antibody similar to trastuzumab and pertuzumab that can be considered. They looked at this in combination with the chemotherapy you see listed here versus trastuzumab. There was an improved progression-free survival with margetuximab, but it was marginal if you look at that difference being slight, but statistically significant. Maybe more of a benefit in patients with a particular genotype of HER2 disease with the CD16A genotype, potentially there being a preference there. HER2 CLIMB, so this was our triplet regimen with tucatinib that we mentioned. So again, a refractory patient population had received previous lines of treatment. So adding tucatinib improved progression-free survival, and really what I want to highlight here is they included many patients that had brain mets on this trial, which is sort of unusual to see. And some of these patients even had untreated brain mets. So you could see us highlighting that patient population in particular, a great hazard ratio of 0.48 in these patients with brain mets. So an option for all patients, but particularly does seem to have activity in those patients with brain mets, even untreated brain mets. NALA trial with neratinib and capecitabine, I just highlight that this is an option. We said kind of fourth line setting and beyond. And it did have improvement in progression-free survival compared to a historic standard of lapatinib and capecitabine. Diarrhea is definitely of concern here with both of these agents, neratinib and capecitabine, so an important monitoring point for our patients. So I've mentioned HER2 low in this designation. So these are patients that don't meet the qualifications for being HER2 positive, but have some degree of HER2 expression. So you see the definition listed here as immunohistochemistry of 1+ or 2+ with FISH negativity. So this is a pretty decent portion of patients with breast cancer. 60% fall into that HER2 low category. Some of them are HER2 hormone receptor positive, some aren't. So historically, even though they had some degree of HER2 expression, HER2 targeted therapies that we've been talking about really didn't benefit these particular patients. So historically treated them as being HER2 negative. We now know that there is one drug that has benefit here, and that's this trastuzumab deruxtecan antibody drug conjugate. And this was based on the DESTINY-Breast04. So this was another really exciting advancement in breast cancer that looked at these patients that had been previously pretreated, so previously received chemotherapy, randomized to this antibody drug conjugate or physician's choice of chemotherapy. And what was found here was a really dramatic improvement in progression-free survival and overall survival in both patients with hormone receptor positive, when they specifically looked at those, as well as all patients, so including those triple negative patients here. So mentioned ILD as being an adverse effect that's very notable with trastuzumab deruxtecan, so that's an important one to remember associated with this drug that needs to be monitored for and counseled with our patients. And we previously talked about kind of where this drug fits in, not first line, but kind of beyond that for those HER2 low patients. A little bit, we're going to wrap up with some supportive care topics. A lot of our patients with breast cancer will develop bone mets. We said breast cancer likes to go to the bone. So we're going to talk through a patient case here of FR, 37-year-old premenopausal woman, newly diagnosed breast cancer with bone mets. Her pain is well controlled at this point. She has hormone receptor positive, HER2 positive disease, and is planned to start chemotherapy with HER2 targeted therapy. So we said here, our only option in the first line setting that we would consider for a patient like this would be the chemotherapy, HER2 targeted therapy with docetaxel, trastuzumab, pertuzumab, so THP. So in addition to this chemo, which of the following would be the most appropriate regimen to prevent skeletal related events or SREs? Would you choose denosumab 60 milligrams sub-Q every 6 months, pamidronate 90 milligrams IV every 6 months, zoledronic acid 4 milligrams IV every 12 weeks, or denosumab 120 milligrams sub-Q every 12 weeks? Okay, excellent. So I agree with the option here, correct, being zoledronic acid 4 milligrams IV every 12 weeks. NCCN gives preference to the every 12-week schedule for zoledronic acid compared to every 3 or 4 week schedule for bone mets. The option for denosumab, that option A here, every 6 months, this would be a patient with osteoporosis or osteopenia, not a patient with bone mets. Option B, so pamidronate, you would not do every 6 months, so the duration or the frequency there is incorrect. And then our last option here, denosumab every 12 weeks. How many see this in practice? I see it too. So it is not in guidelines. So it's one of those things you may see in practice. There have been smaller trials reporting that You kind of mixed results here, but you may be able to find something that supports doing this. But in terms of your guideline-driven option, that's the zoledronic acid every 12 weeks. So just to point out, SREs are a composite endpoint that we see in a lot of these trials that looks at things such as pathologic fractures, spinal cord compression or collapse, the need for radiation or surgery, and then some of these trials also looked at risk of hypercalcemia. So I just want to point it out that these are the things that we're trying to prevent with the use of the bisphosphonate or the rank ligand class. ASCO has a guideline, as they do for a lot of breast cancer topics. So options here that are appropriate are listed. So these are patients with metastatic disease to the bone. So you see pamidramate every 3 to 4 weeks listed. Zoledronic acid, they give the options for every 12 weeks or every 3 to 4 weeks. It's a long-acting drug. NCCN gives preference to that every 12 weeks, but ASCO says either are fine. And then you see denosumab, our rank ligand inhibitor, as an option every 4 weeks. We want to monitor serum creatinine with our bisphosphonates and dental exam, as all of you know so very well. When we look at specifically the comparison of these two agents in breast cancer, so our rank ligand inhibitor with denosumab versus zoledronic acid, you see that where the improvement is a median time to first skeletal related event, which reached superiority as well. So some improvement with denosumab in terms of that endpoint. In terms of the schedule, so I was talking about that every 12-week schedule, this really comes from the OPTIMIZE-2 trial that looked at giving zoledronic acid every 12 weeks compared to the every 4-week schedule. You can see that really the proportion of patients with skeletal-related event was fairly comparable in these two groups, so kind of leading us to believe that the every 12-week option is a good option for patient with less adverse effects. So non-inferior with a longer schedule, and NCCN, we said, has that preference. So just a few things to wrap up with breast cancer survivorship. We certainly hope, especially in the early stage setting, a lot of our patients are curative intent. So we'll live, and even in the metastatic disease, I would say a lot of these patients can be treated with the advances we have as more of a chronic disease state. So we have a lot of patients living for a very long time, which brings some of these supportive or survivorship topics to the forefront even more than they would be otherwise. You can see the physical effects listed here, so dealing with a lot of neuropathy, potentially with the chemotherapy options we've been talking about, especially with those taxanes. Fatigue, lymphedema as a result of their surgical procedures, bone loss as a result of our endocrine therapies, sexual dysfunction, premature menopause, all things that can be very detrimental to quality of life. Potential for secondary cancers based on some of the chemotherapy agents we've been talking through, and psychosocial effects. So just briefly, a little bit more detail about those vasomotor symptoms. So hot flashes, very common in patients getting endocrine therapies. The majority of our patients, we said, are hormone receptor positive and will need to receive endocrine therapies. Chemotherapy and tamoxifen can cause more frequent and more severe hot flashes than natural menopause. So our patients may be particularly affected by these agents and can have a significant impact on quality of life and may even affect adherence to some of our endocrine therapies. So an important thing to pay attention to be counseling patients up front and monitoring as we move forward. So there is some recommendations listed here. It's not all-inclusive by any means, but some options for non-pharmacologic options here with some data with exercise and acupuncture, some recommendations for loose-fitting or layered clothes so that you can kind of adjust throughout the day. Non-hormonal pharmacologic options you see here with SSRIs or SNRIs, some data with gabapentin or pregabalin, clonidine potentially in refractory cases, and then herbal supplements can be considered in patients. Just a word of caution for those products that maybe contain those plant-based estrogen or phytoestrogens that may be problematic, particularly in those hormone receptor positive patients where you really don't want to have any hormone influence there with tumor growth, so really trying to avoid those in that hormone receptor positive patient population. Just very briefly mention a tamoxifen interaction with antidepressant effects, so SSRIs and SNRIs that are listed here. This is a bit controversial, so I'll just point out that there certainly is data here, but there is a little bit of controversy in how clinically significant. So some studies have called this into question. But I will say that we tend to, because tamoxifen needs to be converted to its active metabolite endoxifen by CYP2D6, we really want to try to avoid anything that is a strong inhibitor of 2D6 to potentially, so we're not impacting that level of the endoxifen that's needed. So we try to avoid things that are here like fluoxetine, paroxetine, and bupropion that have that more significant concern. So we talked about issues with bone mets. I like to also just mention bone loss. So that is problematic, particularly with a lot of our endocrine therapies. It's more severe and more rapid with these therapies than what we see with the natural aging process. Denosumab and our bisphosphonates are again going to be kind of what we're reaching for here with our options. So we can see bone loss with chemotherapy, LHRH agonists, tamoxifen, and our AIs particularly. So bone loss being really big there. Our last patient case, AH, 50-year-old postmenopausal female receiving adjuvant letrozole for 5 years for early stage breast cancer. Her baseline DEXA reveals a T-score of negative 2.7, so she has osteoporosis. She is taking calcium and vitamin D. So in addition to encouraging physical activity and continued calcium and vitamin D supplementation, which of the following is most appropriate for her based on her DEXA result? Would you initiate denosumab every 6 months, observation, increase her calcium and vitamin D supplementation, or initiate zoledronic acid every 4 weeks? Okay, excellent. So denosumab every 6 months here being the correct answer. Because she has osteoporosis, you would want to initiate pharmacologic therapy. She's on an AI, which is going to cause further bone loss. She's on adequate calcium and vitamin D, but you could certainly look at that, but that wouldn't be something I would do alone. And then in terms of your zoledronic acid, really pointing out here that the every 4-week schedule is not appropriate unless a patient has bone mets. So if I told you zoledronic acid every 6 months, that could be an option. Okay. So the algorithm for these patients when we look at kind of bone health, bone loss in these patients, so recommending physical activity, adequate calcium and vitamin D, so really asking them how much, not only are they taking it, how much they're taking it, potentially consider interactions with PPIs and choosing your calcium product. And then getting those DEXA scans at baseline and every 2 years and acting based on the T-score. So if the T-score is pretty good, you just can observe, repeat DEXAs every 2 years. For those between -1 to -1.5, you can consider checking a vitamin D level, but really can just continue with observation. For those with T-scores and more in the osteopenia range, so -1.5 to -2, vitamin D levels, consider your pharmacologic therapies here and monitoring DEXAs. And those with T-scores of less than -2 or high FRAX 10-year risk scores, this is when pharmacologic therapy is strongly recommended. So zoledronic acid, denosumab are recommended every 6 months, and close monitoring of DEXA scans. We did it, everyone. You should be very proud of yourselves. Congratulations. Enjoy your evening. Yeah.